welcome. Welcome in this wonderful Council's IRCAD venue. And for the last 3 years, this masterclass was sponsored by the IRCAD on behalf of Jack Marisco and at the benefit of 3 international societies, which are ESPES, IPEG, and ESPU for urology. Since 2018, ESPU assumed with us its preparation and collaborative success. We are grateful to the delegate of these major international societies, Philippe Savaille from Lucerne, who is representative for Europe in the IPEG board, Henri Steyert, the current president of ESPES, and also Ramna Subramanian, who is in Leeds. I don't know if we have a connection with Ramna. Ramna is on the screen.
Yes, I am here.
Good afternoon, Ramna. Very good, great pleasure to have connection with you. And you are the General Secretary of ESPU. Now welcome to our 6 eminent speakers, which are Paul Philippe from Luxembourg, Arnaud Bonnard from Paris, Ciro Esposito from Naples, Ala El Ghonaimi from Paris, Mario Mendoza from Bellinzona, and Miguel Gelfand Faros from Chile. Thank you, Miguel, for the long trip. We think that IRCAD Masterclass has some specificities. First, the trends to excellence in video technology and innovation, the most extended worldwide surgical mailing list, and the most awarded surgical education center for years. Many thanks also to numerous people in IRCAD working with us for this success. And now François is giving some advice and a good trip to have a success in this session. Thank you very much.
Thank you, Philippe. Philippe is the father of this session, and welcome in Strasbourg IRCAD Center. 3 topics will be treated with 2 experts for each topic. Of MIS in pediatric surgery, minimally-invasive surgery in pediatric surgery. During and after the talks, but during the talks, please contact us using the chat for asking questions and discussing. Please do not hesitate. That's very important. Otherwise, there is no life in this masterclass. This is the aim of this. Answer your questions and to open a wide discussion. When you say works, that's very important too, to know exactly who you are. But if you want to stay anonymous, you can. That's, well, it doesn't matter. So now, Philippe will begin.
Thank you very much, François. It's my great pleasure to be here at the 4th edition of the Masterclass. And I'm happy to introduce the first subject we are dealing with today, and that's feeding problems in children and how we deal with it surgically. And it's my pleasure to introduce the 2 speakers. The first one is my friend Miguel Gelfand from Santiago, Chile. He's a professor of pediatric surgery at the Ezequiel González Castro Children's Hospital and the Clínica Las Condes in Santiago, Chile, where he's running a comprehensive center for neonatal minimal invasive surgery. And he's a very experienced pediatric surgeon. He's also a very long time member of IPEG and one of the future incoming presidents of IPEG. And on top of that, he is the host of the next week IPEG Congress in Santiago, Chile, which will be a great success so far. And he's talking about open gastrostomy versus PEG. And then we will have a debate with my friend Mario Mendoza. He's a pediatric surgeon from Bellinzona in Switzerland, so the same country. He's the chief of pediatric surgery there. He has been trained in Mexico and after that at the Johns Hopkins in Baltimore, and then worked in Paris together with Philippe Montopé. And 18 years ago, you started working in Switzerland, first in Lausanne and Geneva, and then you became the head of the Bellinzona Pediatric Surgical Department. Your talk, Mario, will be about laparoscopic gastrostomy, and then we will have, hopefully, a lot of questions about those two topics, and I'm looking forward to both of your talks. And please, Miguel, go ahead.
Thank you, Philippe. Thank you for being here. It's an honor. First time here, so I'm delighted to be here among friends. And thank you, Francois and Philippe, for the invitation, and Rui and Philippe for the chairman, and all of these guys that we are known each other for a long time. So thank you. My talk will be about open gastrostomy versus PEG, what to do, what we know, and how we'll get from each other. I have no financial disclosure to mention, and usually, gastrostomies have a lot of indications. There are several, usually for severe dysphagia, failure to thrive, frequent aspiration, gastric decompression, among others. Sorry. We have several options of different gastrostomy techniques to deal with. From the either open gastrostomies, laparoscopic, percutaneous endoscopic, and the interventional radiology gastrostomies. But there are common complications from each one of them, and they are common from all of them actually. Like intraoperative complications, the hollow viscous injury is the well-known. Early postoperative complications, usually they're dislodgement of the tube and infection, and remote ones. There are granulation, skin ulceration, and some fistulas as well. But we need to discuss only two of those to decide what to do. So we're going to deal with open versus percutaneous endoscopic gastrostomies. And usually there are two kinds of open gastrostomies. The known well is stam gastrostomy, and usually it's done by a midline laparotomy. Then you have to put one or two burst strings on the arterial wall under great curvature, then through a stand wood deliver the gastrostomy tube, and then you have to stick the stomach to the abdominal wall to secure it as well. This is how you usually, or some have usually did it in the, before. On the other hand, the PEG, the percutaneous endoscopic gastrostomy, is a gastroscopy done under general anesthesia. Through a gastroscope, you puncture percutaneously the stomach, put a wire, and then snare with the endoscope and deliver the gastrostomy tube through the white wire, through the abdominal wall, through the abdominal the gastric wall, and then reposition the gastric tube with a new gastroscopy. And the change of that tube afterwards, usually between 3 and 6 months, they will need another gastroscopy. This is how usually is done. So, how to decide what to do? Are we going to use a percutaneous endoscopic gastrostomy or an open gastrostomy? Usually, and this is overall for all the gastrostomies in children, there are no currently consensus about which is best for the children, how to do and when to do a gastrostomy. There's a paucity of well-designed trials. There's no any randomized trial with a level 1 to decide what to do. And nowadays, the most used ones, gastrostomy techniques are percutaneous, laparoscopic, or intervention radiology. And basically, they're only retrospective studies. So there's no big data, there's small series, and no level 1 information about this to decide if we're going to do a percutaneous or open gastrostomy and which is better. Usually the percutaneous is considered a safe and reliable method for performing gastrostomy, avoids a laparotomy. Only the thing is you will need a second GA for the change of the tube. There's some limitation, usually for age of the patient and some like esophageal stenosis, the morbid obesity, ascites, another thing that avoid to do a safe percutaneous gastrostomy. On the other hand, open gastrostomies are usually as well considered reliable and safe, but need a laparotomy and usually are more painful and the length of stay is longer. So what to decide? How to decide this? We need to see what the published data tells about this. This is a retrospective study from the Netherlands in 2017 with 238 patients. The main indication for the gastrostomy usually is the feeding disorders. But among the complications, there were 22 deaths, only one related to the percutaneous endoscopic gastrostomy, but basically there's no statistical difference among open or PEG gastrostomy. In terms of short-term complication as well, open had 64, PEG has 56, but no statistical difference. In the long term, again, the open has 100%, the PEG has 63%, but in this time, the open gastrostomy has a higher incidence and statistically importance of higher incidence of peristomal leakage and mucosal prolapse. So in this study, the conclusion was the other gastrostomy has minor complications. The open one has a risk of a major complication, and PERCs obviously require second anesthesia. But the main thing about this study was the major complications, the serious one, only were seen in the PEG group. This study, again, at retrospective, a huge one in the 2015, and evaluates all the published data up to the date, and they resume it with the available literature, the complication rates, and the resource utilization of these papers. And at the end, they got 22 studies with more than 5,300 participants. Among all these papers, in terms of major complication, they didn't find any difference between PEG and open. Although the length of stay as well, there's no difference, and unbelievable, they have no difference in all the published data. The cost, at this point, obviously the open was 2 times much, the costs were higher compared to PEG because basically of the surgery and the length of stay. The procedure time, there was less in the PEG compared to the open. Other paper is, again, a retrospective study in the 2016 from the Columbus in the Children's Nationwide. From 468 patients with 202 open and 181 PEG patients. In terms of complication, the open gastrostomy versus the PEG gastrostomy show a very neat difference. The open has higher incidence of tube dislodgement and higher incidence of returning to the emergency room and requiring a surgery within 30 days, higher than the PEG gastrostomies. But more often, and this is very important, in the open procedure, from the dislodgement of all these patients that had a dislodgement, 80%, almost all 80%, came from the open procedures ones. The conclusion of this paper was that the open gastrostomy was associated with an increase, an important increase in the tube dislodgement and return to the emergency room within 30 days. This is the last one that we review. This is a paper from 2013 from Sydney, Australia, with a 369 patient with 260 laparoscopic ADC PEG and 23 open patients. The mean operative time of those patients showed that the PEG obviously took a significant shorter time compared to open. Early complication open versus PEG, there's no statistical difference. Late complication open versus PEG show that open has higher incidence of late complications compared to the PEG patients. In terms of major complication, talking about gastrocolonic fistula, peritonitis, or Barrett-Bumper syndrome, the major complication only appeared in the PEG patients. In terms of overall complications, the difference of open versus PEG was that the open has a higher incidence on overall complication and leakage compared with the PEG patients. So reviewing all this data, it was very difficult to decide if I had to decide to do a gastrostomy patient, to do a percutaneous endoscopic gastrostomy or an open gastrostomy. So these are how we go through. The percutaneous endoscopic gastrostomy has pros and cons. Which of the pros that found all this literature published has a lower length of stay, the costs were lower, and the time procedure was lower. The cons in PEG was that had a major incidence of major complication, required a second general anesthesia, and had limitation, age, obesity, and other contraindications. In the hand of the open gastrostomy, the pros are that you can do it at any age, you can secure the position of the gastrostomy tube, and sometimes you can dissociate with a fundoplication if needed. The cons are that a higher incidence of minor complication and a much higher incidence of tooth dislodgement. So again, what we do? And so I called Mr. Jeffrey Ponsky. I don't know if they know Jeffrey Ponsky, who invented the percutaneous endoscopic. And there's no sound, but basically he told me that doing an open gastrostomy is the same as having a new car, like a T-Mobile car. There's a video, but it's saying that. So I have to merge what to do now. So I have to decide how I pick the good things about the percutaneous endoscopic gastrostomy and put it together with the good things about the open gastrostomy and merge them. So what is found that the hybrid technique of a laparoscopic assisted percutaneous endoscopic gastrostomy is the better word for in between both of them. This is done a PEG under direct view of the laparoscope. It's a very simple procedure. You have to put a single 3 to 5 millimeter trocar or camera through umbilicus. You have to slightly insufflate the abdomen just to see the gastric wall, and then do the procedure of our normal PEG, but just under direct visualization. This is done basically in patients that first you have to be secure about the gastrostomy. Can have some altered anatomy like scoliosis or previous surgery. There are obesity, they have ascites, but basically doing this you prevent any hollow viscous injury and the correct position of the gastrostomy. This is how it looks. This was a patient that had a surgery before, has some additions, basically from the gastric abdomentum in the abdominal wall. We've seen this through the umbilicus, and we managed to go through the additions and just have a nice view of the greater curvature of the abdomen and the stomach. You can see the addition from the stomach to the liver. And basically, you deliver then a normal percutaneous endoscopic gastrostomy with a secure view of your laparoscope. You slightly insufflate the stomach just to be sure that you're in the right position with the gastroscope. You decide where to put it in the stomach, and then decide where to put it in the abdomen as a normal usual procedure for a percutaneous endoscopic gastrostomy. And then just to puncture the abdominal wall and the gastric wall with direct view, with a safe measure that you are going to do any harm in the patient. And then proceed with the normal endoscopic retrieval of the gastric tube. And then see how it looks, secure in the right position. There's many literature about this, and this is what I've been doing in the last 10 years in our hospital. The laparoscopic assisted percutaneous endoscopic gastrostomy, basically the lap plus PEG, improved the visualization of the abdominal cavity, making it very secure, minimize or go to zero the visual injury. You put a safe placement in a complex patient, like scoliosis or patient with previous surgery, and basically it's the same length of stay of the PEG patients. The PEG is slightly cheaper than the lap PEG, but definitely is cheaper than the open because of the RTAM material. But it's safer and it's cost less. So the summary, the laparoscopic assisted percutaneous endoscopic gastrostomy has less complications, less space in with the open gastrostomy.
Thank you very much, Miguel. Very comprehensive talk about both the procedures. You took a small part from Mario about the laparoscopic procedure. And we go directly to the next talk from Mario, presenting the laparoscopic gastrostomy procedure. And then after that, we're going to summarize that, and we'll hopefully have a fruitful discussion about those. Mario, go ahead.
Thank you very much, Philip. So first of all, I would like to thank quickly François Becmour and Philippe Montupet for organizing this 4th edition of the Masterclass. Thank you also for the invitation, and a special thank to Professor Marisco and all the IRCAD crew for the support of this continuous Masterclass that is becoming now a tradition, and I hope it will last for many years. Thank you very much. So after the very nice talk of Miguel, I'm going to talk about the laparoscopic gastrostomy in children. So I don't have any conflict of interest to disclose, and I'm going to talk mainly about indications, the technique. I'm going to talk some gastrostomy tubes, buttons, complications. We will take some take-home messages, and at the end we will give the time for questions. So why a gastrostomy in children? As Miguel said, because sometimes we need to guarantee a long-term feeding in children that unfortunately sometimes are unable to use the oral route, or to take sufficient nutrients, or to maintain growth and development. Situations that generally include children with cerebral palsy, inherited metabolic disorders, gastrointestinal disease, abnormalities of the swallowing mechanism, abdominal severe trauma, burns for caustics, renal disorders, oncology, cystic fibrosis, and so on. So, okay, we need to decide to make a gastrostomy. How could be the best way to do it in a child? And I think the question is by a minimal approach. Minimal invasive surgery for gastrostomy was introduced in 1980 with the first publication of the percutaneous endoscopic gastrostomy, and 10 years later became also the laparoscopic gastrostomy. Since then, several publications, as Miguel showed you, have been published about the good results and the benefits of the laparoscopic approach. And more recent publications come comparing, as Miguel showed you also, the different techniques, especially between open, the laparoscopic approach, and the percutaneous approach. And what is interesting is that many of these articles show in the results that laparoscopic gastrostomy has the lower risk of major complications compared with open or with the PEG approach. This is changing with the hybrid technique that Miguel just showed you also about the, that combines the laparoscopic approach and the PEG. But we are waiting still for more evidence. We need more publications to confirm if this is true, because still, even with the video-assisted PEG, there are still some complications of the PEG that we don't see in the laparoscopic approach. So up to date, we have 3 main approaches to perform a gastrostomy in children. One is the laparotomy. The stamp, for example, is the more popular, the laparoscopic approach, and the percutaneous. In my talk, I'm going to concentrate mainly in the laparoscopy. I will not talk about the radiologic percutaneous or the video-assisted PEG. So, thinking about main indications just for laparoscopic approach, we can think in situations where the child has to have another procedure. And especially these procedures are related to anti-reflux surgery. Or it can be also for pyeloplasties, pyloroplasties, or for other type of gastric disorders. Another good indication for laparoscopic approach is severe scoliosis. Neurological impaired children have a very weird anatomy. Everything is completely different, and the risk for an open or a PEG approach increases the risk for complications, for major complications. Neonates and small children, you need to remember that most of the devices of the PEG are too big for small children. Obesity also complicates things for open surgery or for percutaneous. So these are very good indications for laparoscopic approach. But in my opinion, which remains the main indication still today, is the surgeon's preference. The surgeon experience is very important to decide which one of the methods will be the better to perform. Contraindications for laparoscopic approach should be the risk for pneumoperitoneum, which means patients with severe pulmonary disease, with severe cardiac disease, with severe acute illness, or a relative contraindication previous abdominal surgery. Of course, it depends on the type of the procedure that it had before or the number of previous surgery. Regarding the techniques, the patient is placed in supine. The surgeon can stay at the right of the patient, or it can be also at the lower end of the table. Ports placement, the umbilicus, the first one, could be a 5 or a 10 millimeter, depending on the age of the patient. The second port is the tricky one because it should be placed at the level where the gastrostomy should be coming out. And you need to remember that stay far from the lower edge of the ribs, especially 2 or 4 centimeters, depending on the age of the patient. You can have a third port access, and if it's the case that the patient will have other procedures, you can have accessory ports that will make things easier. Of course, neurologically impaired children with difficult cases like severe scoliosis, you need to adapt the port settings in the anatomy, to the anatomy of the patient. So, this is why laparoscopic gastrostomy has the best strength points, because you have control of everything. You can see what is going on inside the abdomen cavity, and you can, on the direct vision, select exactly where the position of your gastrostomy is going to be. And you can have a very good idea about the gastric anatomy. As you see in this patient, we have performed it before Nissen funduplication. Once you have decided where to place your gastrostomy, you can put 2 or 3 anchor sutures with a reabsorbable material. And then once you have put your anchor sutures, these anchor sutures will help you to give stabilization to your gastrostomy, to fix the stomach to the abdominal wall. And once you have set your anchor stitches, you can use 3 techniques to introduce the G-tube in the stomach. One is pulling the stomach through the port, as I said, in the upper left quadrant, and put it with a Seldinger technique, making progressive dilatation until you reach the diameter of your tube. Introduce usually a balloon tube, and then fix it and tie in the anchorage sutures. This is one technique. The second possibility, if you don't have a Seldinger technique, is to approach the stomach to the port of the left quadrant, make a micro laparotomy in order to get some piece of stomach out extracorporeally. You can perform a pull string suture, open the stomach, introduce also your tube, close the pull string suture, and then tie again the anchor sutures. The third possibility is to perform like a video-assisted PEG. So these are the 3 possibilities that you can perform. Obviously, for the PEG, video-assisted PEG, it shouldn't have the problem of the babies, because it's difficult, the device. In this patient, for example, I decided to perform the micro laparotomy. So I perform also the pure string suture. I introduce the tube. And before suturing the anchor sutures, I was controlling and the direct vision, the position of the gastrostomy, and pulling the stomach to confirm the situation. This is the final, the finish of the surgery with the anchor sutures already tied. There is a second possibility to fix the stomach to the abdominal wall, and are the T-fasteners. There are very few publications about the experience of T-fasteners in children, and some of these publications report major complications such as infection, migration of the T-fasteners, and gastric perforation. Personally, I don't have any experience with these T-fasteners, but it could be another option for fixation. Regarding gastrostomy tubes, you can have a wide variety of choices. The industry offers many things. You can go with a classic Petzer or Mallecott catheter, or you can use a conventional G-tube with balloon, or in case of emergency, you can also have a Foley catheter that are also very safe. Otherwise, you have all the PEG devices that you can also insert directly. This is the Ponsky system, which is a very good one. I like a lot this system because it's very soft, and especially when you need to change the tube or replace it for a button, this system doesn't need any gastroscopy. You just pull it and it comes out very easily. There are the other system, which are the discs, that these need a gastroscopy for removal, and there are some others, not balloon devices, that you can use. The external bolsters are very important because they allow you to get stability to your tubes. They decrease the risk for leakage, and they decrease also the risk of migration of the tip of the catheter, especially when they have balloons. They decrease the risk of obstruction of the stomach. 3 months after the gastrostomy, the tube could be replaced by a button. And here also industry offers many, many choices. Personally, I prefer the low-profile buttons with balloon. The idea is to set the best button for the patient, and for this you need to measure the length of the fistula. The gastrocutaneous fistula need to be measured. There are different devices for measure it. There are also with balloon. So you remove the tube, you insert the device, you measure the length of the gastrocutaneous fistula, and then you fit the button that better goes with it. Then, to taking care of the button, as everybody knows, you need the objective is to keep it as dry as possible. You need to turn the button at least 1 time per day, 180 degrees. You need to avoid ointments, you need to avoid creams, and you just need to clean it with water and soap. You don't need particular things to do. For the balloon, you have different options. You have the distilled water that you need to control at least once a week, because remember that the balloon has a micropore, the silicone has micropores, and the water escapes very easily. So you need to control it at least once per week. If you don't want to deal with this problem, then you can use water with glycerin. And in this way, you just control it once per month. Remember just that here you will have the adverse effect that the water will get into the balloon. So if you don't control it at least 1 per month, you will have the problem that the balloon is going to be filled always at the maximum capacity, and this will decrease the life of your button. These are the liquids that you can find outside, the glycoblock and the Dover, that they work very, very good. The other thing that is important to know is about the system for attached to the button. There is the unlock system and the lock system. I prefer the unlock system. And this is because sometimes happen that accidentally somebody can pull the tube. And if you have an unlock system, you can see the tube will release from the button, and then the balloon will stay stable. If that happens with a lock system, the tube will take also the button out, and then the button is going to be damaged for sure, and also it's going to be an important damage of the stoma. So talking about complications for laparoscopic gastrostomy, minor complications, which is another classification different from Miguel. I classify in minor and major complications. Minor is 3 to 14% for laparoscopic gastrostomy, which includes wound infection, tooth removal by accident, granuloma, and the buried bumper syndrome. It's depend, because sometimes if it's just a low problem, it could be considered as a minor complication. If it's causing also ischemia or necrosis of the gastric wall, goes into the major complications. Major complications are reported 1 to 3%, which is very low in comparison with PEGs. These include gastric perforation, bleeding, subcutaneous abscess, ulcers, chronic gastrocutaneous fistula after tuber removal, peritonitis, ileus, and something very interesting is that there is no death reported related to laparoscopic gastrostomy in children, which is not the case for PEG. Tube-related complications are dislodgement, balloon dysfunctions, migration, and obstruction. Another important complication that is more related for PEG is the gastrocutaneous fistula, which in laparoscopic gastrostomy it has not been reported in children. One of the main complications that we face for any type of gastrostomy is granuloma, and also for laparoscopic approach, we can face it. It has been reported an incidence of 25 up to 55%, and remember that this is most of the time secondary to leakage. So when you have a gastrostomy tube or a button, and you have the external bluster that fits into the skin, the best way to control if everything is going good is pulling just the catheter, and the external bluster shouldn't reach more than half a centimeter away from the skin. If that happens, that means that the length of your button or the fixation of the bluster is perfect. But if it has more than half a centimeter, that will have a problem because the button is too long or the bluster is not working good. That means that the gastric fluids are going to be spilling outside of the stomach, and gastric content is very acid, and it will start to cause a peristomal chemical burn. And if this continues at the end, sooner or later, the gastric metaplasia granulation tissue will start to come out, and then you will have your beautiful granuloma. You can try to cauterize, you can try to put antibiotics, you can try to do everything, but if you don't control leak, it will not change things. So what to do in these cases? Interrupt leakage. You need to adjust your button or change your tube. If it's just a temporary leaking, you can increase the wall thickness by adding different levels of gauze or another absorbable material. You can change your button or choose a shorter button. You need to decrease the skin irritation by cleaning with water and soap, skin protection with Cavilon, and use the gauze or absorbable material. That should be changed very often. Attention with Vaseline. All the unguents destroy silicone. So be careful about unguents because the Vaseline corrodes silicone. Antibiotics are very rare because this is a chemical burn, so the acidity will not even allow bacterial development. And following these steps, in a matter of 3 or 4 weeks, most of the granulomas will be under control. So what are the take-home messages for the laparoscopic gastrostomy? The first one, laparoscopic gastrostomy offers good results in children with feeding difficulties, children with failure to thrive, or with severe GI dysfunction. The second one is the best indication for laparoscopic gastrostomy may be related, if we need to choose between a PEG or an open or laparoscopic, if the child needs another surgical procedure at the same time, if it's a small baby, neonates, or small children, severe scoliosis, obesity, but as I said since the beginning, the main indication remains the surgeon's experience and choice. Which one could be the best tube or button? And this depends also on the surgeon experience and depends also about the availability that you will have in your hospital or in your country. And finally, laparoscopic gastrostomy in children is safe and feasible and has a very low risk of major complications when compared to PEG. As a matter of fact, many pediatric surgeons think that laparoscopic gastrostomy should be considered the gold standard for performing gastrostomy in children due to the very low risk of major complications. Thank you very much.
Thank you, Mario. Very good talks. Very interesting topic. When I saw the topic or the titles of your talks, my first impression was there should be a significant difference in both the approaches, either open or the PEG, the conventional PEG, or the laparoscopic approach. However, now having listened to your talks, it seems that you kind of focusing on the same thing, because in the end of Miguel's talk, he was preferring the laparoscopic assisted PEG, and with your talk, Mario, you are preferring the laparoscopic approach. So in the end, it ends up that the laparoscopic approach, either by a small mini laparotomy and then the insertion of the tube, or the PEG technique, which you advocated, seems to be the best deal. So what are we talking about? It's an issue of complications. It's an issue of costs. It's an issue of surgical invasiveness. And what raises my first question is, what is very, very precise your age and weight limitations, either for the open or the PEG system or for the laparoscopic approach? You both mentioned it, that there is kind of limitations due to weight and age, but can you be, both of you, more precise, and what would be the lowest weight or the smallest age in which would you find your method of gastrostomy insertion most applicable?
Okay. Regarding the limit of age for laparoscopic gastrostomy, there is no limit of age. Depends also, of course, of the stability of a neonate, and your anesthesiologic team, they need to agree to perform that. Because otherwise, sometimes you need to perform an open gastrostomy in a neonate. But there is no limit in reality for a laparoscopic approach. A limit could be a financial thing, because if you want to perform a video-assisted PEG or a PEG, you need to have gastroscopies for children. You need to have experience with gastroscopy, and of course the material. Sometimes these catheters are not very easy in some countries. So the laparoscopic PEG, the skills for laparoscopy are necessary, but it's like an appendicitis. It's like a relative simple procedure, and you can find always a Petzer or a Foley catheter to perform a laparoscopic gastrostomy. So the cost in this situation is very low. So in my opinion, for laparoscopic gastrostomy, it's an excellent choice. Of course, the video-assisted PEG is something new, and we need to get more information because still major complications are there.
Miguel.
Well, what we have been doing for the last 10 or 12 years is that every chance that we can put a laparoscopic assisted PEG, we do it. We have been having great results with that. Not even a major complication, because of the you do it under vision, so you avoid any major problems. You can have the minor complications of any other gastrostomy, but the procedure is very straightforward, and is the first choice in our institution. In terms of when we can do it, usually it's because of the weight of the patient. You don't have a percutaneoscopic gastrostomy tube for very small children. So usually under 5 kilos, we turn into a laparoscopic gastrostomy. Not because we can do it, because we don't have the device from the tube to go through the small kit. So basically, again, over 5 kilos, I get that 85% of our children get a laparoscopic assisted gastrostomy with no problems, and usually it's a day case at the most, unless they're in the hospital for other reasons. Under 5 kilos, usually we'll do a laparoscopic gastrostomy with the Georgetown style of gastrostomy with percutaneous stitches to secure the abdominal wall.
Miguel, as you're running a comprehensive center for neonatal minimal invasive surgery, did you ever encounter the case that you would like to apply a PEG, but you couldn't get the gastroscope in due to size limitations?
We do have neonatal endoscopes. So usually over 3 kilos, we can do an endoscopy with no problems. The problem is not the endoscopy, the problem is the G-tube device that usually is wider to go through. So it's not the endoscope the problem, is the gastrostomy tube the problem. If we can have one, we can do it right away as well.
So question to both of you, as we all are in favor of minimal invasive surgery, do we need to perform multiple incisions to do a laparoscopic in place of just doing a small incision and do an open, especially in...
I completely agree with what Mario said, that the surgeon has to decide which is better for his patient in terms of what he's able to do. So we can go as far as if an open gastrostomy is what he can do, and he's doing well, he's good doing it, and he has no other choice to do it, he can have to do an open gastrostomy. Hopefully they will change it in time, but basically, in terms of if it will be a laparoscopic assisted gastrostomy or laparoscopic gastrostomy or laparoscopic assisted PEG, the term is you have to do what you think is better for the patient, and the thing you know how to do it better. Basically, is that my answer.
Mario, how long stayed kids with a laparoscopic assisted gastrostomy in the hospital at your place?
24 to 48 hours at the maximum. It depends of we start feeding relatively fast. In the first 6 hours, they are fasted, and then we start giving clear liquids, and then we pass to milk or enteral feeding, normal enteral feeding.
And Miguel, length of stay in your patients?
For the lap-assisted PEG, within the day or at most one night. With the laparoscopic one is one night and that's it. But I want to say something. We started doing laparoscopic assisted PEG because 12 years ago we have a gastrocolic fistula because we have doing the PEG without the laparoscopic view, and that was the only case, and that only problems avoid us to keep doing that without the laparoscopic assistance. And I think it's very important to say that if you're doing just percutaneous endoscopic gastrostomy, at some point, at some day, you will have a major problem. It's impossible not to have it. And if you are the best one in the world, you will have it.
I agree.
So I think the people who is doing just percutaneous gastrostomy, if they can do it simultaneously with laparoscopic assistance, they have to start doing that and stop doing just percutaneous PEG.
I agree. Technical question from the internet. Why not put directly a button into the laparoscopic assisted gastrostomy access? Because Mario, you were talking about putting a Malico or a classical Foley or whatever is suitable in, or even a PEG. Why don't put the button directly into it? Okay,
well, the risk is it's possible to put a button, and with the laparoscopic approach, you have the possibility to fix the stomach to the abdominal wall, which makes things easier and safer. Something that you cannot do if you perform a placement without fixation of the stomach. But the button is also possible.
Okay.
So can I add something?
Sure, Miguel.
You can do it. The problem is that the button has, you have to fill the balloon, and the problem with the balloons are they get deflated, and then you may get a problem. Again, it's the same as the PEG. You can do 100 buttons in the gastrostomy at the first time and don't have a problem, but 101 you may have a problem. Again, it's possible to do it, but definitely it's more secure to do it the other way, not with the balloon.
As laparoscopy has been established in so many places all over the world, do you really think, or do you honestly think, that there's still a cost problem or a cost issue in comparing those approaches? You mentioned, Mario, that it might be more expensive using the OR and using the laparoscopy tower or the devices compared to a classical conventional PEG or even the open approach. What both of you think about the honest cost relevance of the three different approaches: open, PEG, laparoscopic assisted?
Well, it obviously depends where you are. If you're a small country that is underdeveloped and you have no money, the problem is solved, but basically you won't have any laparoscopic instruments. But if you have those and you're running any kind of surgery, even if there are small ones, laparoscopically, day by day, definitely it's worth it to do it. The cost, at the end of the day, if you're running laparoscopic surgeries, even if they are small or not major surgeries, compared with the PEG, the costs are even similar. So at the end of the day, it won't be a problem in terms of money.
So it comes up back to the issue of complications, and that's what we were afraid most of it was the colonic or even small bowel perforation in the conventional PEG, or even in the open approach. Is it, like you said or you mentioned already, the best out of two worlds to do the laparoscopic assisted PEG which you advocated. Would you both agree with that in terms of concluding both of your talks?
For example, in my hospital, what we do, generally, if it's possible, if it's a child and not an infant or a small baby, we go with video-assisted PEGs. And we are doing mainly laparoscopic procedures when we are performing some other procedures. That's what we are doing now. Doing the laparoscopic in these cases, obviously, it's more a long stay in the hospital, and the risk of complications sometimes are more related of the primary disease of the patient than by the laparoscopic surgery. But in terms of real complications just by a PEG itself, I think cost can increase if you face a major complication. Instead of doing a video-assisted or a simple laparoscopic gastrostomy for a regular gastrostomy in a non-complicated patient. I think the costs are very low because an experienced laparoscopic surgeon can perform a laparoscopic gastrostomy very, very quick. And you need special materials.
I can answer in one way. I don't do any surgery that I can't see. That's it. So I have to see it all laparoscopically or open, but I will see it.
All right. So in conclusion, I would like to summarize both of your talks that it might be actually the best out of two worlds to do it laparoscopically assisted in terms of seeing what we're doing. I found very convincing what Mario said, that we are not putting gastrostomy tubes in children who are healthy kids. So they all are somehow compromised. They do have special anatomy. They do have special conditions such as other underlying diseases. So laparoscopy, apart or except for except for some contraindications in terms of applying general anesthesia and pneumoperitoneum, laparoscopy seems to be superior to the conventional PEG in terms of avoiding the most feared complications of perforating bowel or the colon. So, do we have questions from the internet? I'm just going to check.
Okay, we just we have the good surprise to get Cindy Gomez Ferreira as a guest for this masterclass, and she would like to discuss a little bit with you. It was not organized, but it's a good surprise, and she's working with Paul Philippe in Luxembourg, so we know very well Cindy, and she worked previously in Strasbourg. So Cindy, could you add some questions perhaps about the risk, everything, the risk of gastroesophageal reflux after gastrostomy, and many different things you can speak about?
Well, thank you, François, for inviting me. I was just around. I learned from the best. And, well, we use laparoscopic gastrostomy in Luxembourg. We perform them because our endoscopist is not fierce to do PEG. But so we have a really good experience in that, even if not the biggest one, because we are a small country. We use the T-fasteners that come from the PEG development to fix the stomach to the wall in older children, not the smallest one, because the anchors like to dislocate. And these T-fasteners come together with the Seldinger setup with a pillow-way introducer that might help introduce also the balloon buttons immediately when we do the gastrostomy. So it was a little remark because there was some question in the air from the internet. I liked really this both topics, because the topic with both presentations, because it really encourages me to do what I do laparoscopically under view, even if I have not the chance to have an endoscopist around. So thank you to you both, and I really enjoy your stay here in Strasbourg.
Thank you, Cindy. Perhaps you have some answer from Miguel and Mario.
I think our experience about the T-fastener, it was not good at all, actually. So we stopped doing it. And so we did a couple of patients, and I didn't like it at all. So we just stopped it.
Yes.
And the other thing is that I know that every country has their own rules and every hospital has their own problems, but I think it's very important for the surgeons to manage the endoscope. There's within the gastroscopy guys and the surgeons, and that it's very difficult to deal with them in a good way at some point. So I really encourage all the surgeons that are listening, that they don't manage an endoscope, to start doing it. I think it's very important for their own safety and for the safety of their own patients. And I hope nobody from the gastrointestinal injury group are hearing me now, but we are much better endoscope surgeons than the endoscope pediatrics at the end. Sorry for that, but it's true.
I have the pleasure to close that topic, and I would like to thank you once again for your very excellent talks and a very lively discussion. I think it covers a lot of the current problems in the subject of gastrostomy in children. And thank you very much again. And we move on to the next topic.
Thank you very much.
And I hand over to, I guess, Ram in Leeds to kind of moderate the next urology topic. Ram, go ahead.
Hi, Philip. Can you hear me?
Yes.
Good afternoon to everybody. So I'm Ram Subramaniam. I'm Secretary of ESPU and a pediatric urologist. I'm really apologize for not being able to be present physically at the venue. It's my loss because Strasbourg and IRCAD is such a lovely site to be in for the meeting. But without taking much ado, just because in the interest of time, it's my pleasure to chair this session on pelvic-ureteric junction obstruction, which is going to explore laparoscopic and robotic approach, excuse me. And we're going to look at transperitoneal versus retroperitoneal approach with distinguished speakers of Ciro Esposito and Professor Alagonemi. So I think without much ado, we can move on to the speakers. And I just want to say that because of my distance that I'm away from, I think Mario is going to help me with any internet questions that will come along the way after the lectures are done. And I hope that's okay with you, Mario. So over to Ciro.
Mr. Chairman, first of all, I would like to thank Philippe and Francois for the invitation. It's always a pleasure to be here. I would like to thank also Professor Maresco to us this fourth edition of this masterclass in Strasbourg. My topic will be focused on laparoscopic and robotic management of pediatric UPJO, and I have the pleasure to share this topic with my friend Alagonemi. I will speak on laparoscopic and robotic approach, and Ala will speak on retroperitoneoscopic approach. As you know, robotic surgery had in the last 10 years an amazing impact in pediatric urology. I had the pleasure to work with adult surgeon 20 years ago, and we published this paper on our preliminary experience in 2004 in surgical endoscopy. As for robotic pyeloplasty, this technique has generated a profound attention in the last year because it presents a lot of advantage compared to conventional laparoscopy, above all for a more rapid learning curve, an increased visualization, and then an enhanced manipulation of tissues. And if you look at this table, is a total number of surgery carried out by several specialties. This is an American institution. As you can see, as robotic in pediatric surgery, there is always small numbers. You can see the red part of the column. In blue is the urology part of adults and the other robotics. For this reason, at the moment, robotic in pediatric urology, there are a small number compared to the other specialties. I will show the little bit the two techniques with some videos, laparoscopic pyeloplasty and then robotics, and then discuss a little bit on the basis of a literature report. In laparoscopy is a true invasive procedure because we use 3 trocars of 3 mm. This is the position of patients. And in laparoscopy is important before starting the pyeloplasty to position a couple of stay suture because you have to stabilize the junction before starting the pyeloplasty. You fix the junction transparietally with a couple of suture, and then the procedure is absolutely the same as in open surgery. You have to perform the spatulation of the ureter, and then you have transected the pelvis. As you can see, it's extremely important to place these 2 stay sutures. In this way, you stabilize the junction before starting the procedure. Then you have to position a 3rd stay suture that is the first suture of the pyeloplasty, and you can perform the same thing. You position this stay suture transparently. In this way, the junction is stabilized and you can start the anastomosis after the resection. And then you have to perform a couple of running suture on the posterior wall using, as you prefer, in general 5-0 or 6-0 PDS suture. You can perform a running suture. As you can see, stabilizing the junction is extremely easy to suture, and then you have to complete the lower part. It's preferable to put a separated stitch, and then we position a double J stent introduced percutaneously. You can introduce the double J stent through an angiocat or through a trocar, and it's extremely easy to do it, and the only disadvantage to position a double J stent is that you have to perform another anesthesia to remove it 1 month after surgery, and then you have to complete the anterior wall with another running suture. As you can see the double J stent inside, and this is the end of procedure. We prefer to leave a drainage inside the abdominal cavity through one of the trocars for about 24 or 48 hours. The problem of laparoscopy is you have a bad ergonomics. We published this multicentric survey a couple of years ago, and all the surgeons that perform long-lasting procedure as laparoscopic pyeloplasty at the end of procedure has shoulder problem because you have a bad ergonomy, wrist problem, back pain. For this reason, this is one of the main disadvantages of laparoscopy for long-lasting procedure. And the answer to a bad ergonomy is robotics. Robotics, using robotic pyeloplasty and robotic surgery, you have a wonderful ergonomy because you are seated on a console and you can work using 3D vision. As for robotics pyeloplasty, we need for trocar 3 robotic trocars of 8 mm. We have the XI, and then we need a 4th trocar for a bedside surgeon of 5 mm because you have to introduce suture inside, you have to cut suture and then to remove the needle. And then you have to perform the docking. For this reason, is not only a pediatric surgeon work, but you need a team of nurses that work with you. And then the robotic is seated at the robotic console to operate. As for the organization of a robotic cooperative theater is a little bit longer because you need to perform the setup of the patients, the port insertion, then the docking that is performed from your nurse, and then you have there is the consult time, the time of surgery, and then the extracorporeal step. For this reason, compared to laparoscopy, is a little bit more complicated, the organization of the operative theater. However, robotics has a huge of advantages. Above all, you know that robotic instrument have 6 degrees of freedom. In general, as instrument, we use a needle driver, a Maryland bipolar forceps, and a scissor. As for the technique, is absolutely the same. Considering that you have 6 degrees of freedom, it's not necessary to put the stay suture as in laparoscopy because it's extremely easy to suture. The technique is absolutely the same. You section the junction, you perform the spatulation of ureter, and then you perform the anastomosis. As you can see, it's extremely easy and comfortable to perform the suture. It's important to remind that you need at least 1 bedside surgeon because you have 3 robotic instruments in general and then a 4th trocar for a bedside surgeon to introduce and to remove the suture and then to cut the sutures. And then, as in laparoscopy, we prefer to position a double J stent. There are several types of stent. You can put also a stent transparently from outside. In this way, it's not necessary to perform another anesthesia. We perform always to position a double J stent. As I told you for laparoscopy, the main disadvantage of double J stent is that you perform another anesthesia to perform a cystoscopy and to remove the stent. And then this is the end of procedure. You can see the anterior wall. Robotic is indicated also for complicated cases, as in this case. You can see this is a pelvic ectopic kidney. You can see the appendix. This is this UPJO located on the right side. In this way, with robotic, is easy to perform the procedure and to perform the suture after resecting the junction and to position inside the double J stent. If you want to give a look to a literature as for these points, first of all, we can speak the difference between laparoscopic pyeloplasty and retroperitoneoscopic pyeloplasty. If you look at the literature, it seems that the operative time is longer for retroperitoneoscopic pyeloplasty, but there is no difference as for hospital stay, analgesic requirement, and cosmetic outcome. And the conversion rate, it seems a little bit higher for retroperitoneoscopic pyeloplasty, but it's extremely important to underline this aspect that the overall success rate, this is a paper of the ALA group, are absolutely comparable. It means that laparoscopy pyeloplasty and retroperitoneoscopic pyeloplasty give the same long-term result. For this reason, at the end, as for laparoscopy and retroperitoneoscopic pyeloplasty, I think that the choice between the two procedures based on his experience. If you want robotic pyeloplasty versus laparoscopy or open, there are several papers. This is another table of an USA paper. As you can see, in the last year, robotics in green have an important impact on pyeloplasty compared to laparoscopy, that it is the red part of the column. However, the limit of robotics, as you can see, that at the moment we work with 8mm instrument. The instruments are too big. For this reason, it's difficult to use this instrument and robotic surgery under 1 year of age. In the majority of papers, they prefer to use robotics for pyeloplasty after 1 or 2 years of age. This is another paper of 7 years ago of Riccardo Torino of ALA Group, and has focused on robotic pyeloplasty, and the conclusion is that the main advantage of robotics pyeloplasty is the precise suturing and the shortening learning curve. And this is another paper comparing pyeloplasty via robotics and open, and this paper underlined that the long-term result of a robotic pyeloplasty and open pyeloplasty are absolutely the same, but robotics has a shorter postoperative stay. And this other paper published a couple of years ago showed that robotics and open have the same long-term result without major complication. I think that, however, to perform robotics, as you know, you need surgical skills. It means that you have to operate at least, you have to perform 20, 30 cases to have a consistent outcome, and above all, considering that it's more complex to organize a robotic operative room, you have to operate at least once a week using robots. Another point of interest is extremely important to well position the instrument, above all a small infant, because you have the risk of clashing between instruments extracorporeally because the robot is too big. And then another disadvantage of robotics compared to laparoscopy is that now we work with 8 mm instrument. There are robotic in 5, but the instrument is not very good as 8 mm. For this reason, in robotics, we use 8 mm compared to laparoscopy, in which we work with 3 mm instrument. And if you want to compare laparoscopy and robotics, it seems that complication after laparoscopy as higher compared to robotics, but it's important to underline that the success rate with a long-term result are similar. There is a little bit difference, but it's statistically not significant. It means that robotics pyeloplasty and laparoscopic pyeloplasty give the same result. For the hospital stay, it seems shorter with robotics. And this is another paper published last year on JLAST, and with the same conclusion that robotics and laparoscopy for pyeloplasty give comparable outcomes. Some consideration before concluding. As for laparoscopic pyeloplasty, this is an advanced procedure. For this reason, you need the laparoscopic skill to perform it. And you have a better ergonomics. In general, the procedure, it lasts 2 hours and is fatiguing for the surgeon. Disadvantage is that you are in transperitoneal way, and in case of a leak of urines, go inside the abdominal cavity. The advantage is that it's a true mini-invasive procedure because you use 3 mm trocar compared to the robots of 8 mm, and in laparoscopy you have a large space to work. As for robotics, the disadvantage are the costs. For sure, you know that the robotic console costs about 2.5–3 million euro, plus the cost of maintenance and instruments. The size of instrument at the moment for each side are 8 mm, and is not so easy to change robotic instrument as we change in laparoscopy. And then the robots outside is too big, and you have a small space to insert additional instrument if you need. The advantage is that robotic pyeloplasty is easier compared to laparoscopic pyeloplasty because you have a precise suture, you have a short learning curve, above all you have a very good view with a 3D vision, and the ergonomics for surgeon is fabulous. Three conclusions. Laparoscopic pyeloplasty, in my mind, is more minimally invasive than robotic because you use 3 mm trocar compared to 8 mm. However, robotics pyeloplasty is technically easier compared to laparoscopic pyeloplasty. Robotics for sure is more expensive than laparoscopic pyeloplasty, and however, the main advantage for surgeon using robotics here, the ergonomics. Learning curve for sure is short, very short with robotic pyeloplasty, and the operative time, all included, probably is longer with robotics. However, it's important to underline that laparoscopic pyeloplasty and robotic pyeloplasty give similar result with a long-term outcome. The main advantage of robotics remain the precise suturing, the 3D vision, and the ergonomics. However, if you look at international literature, robotics is superior to laparoscopy, and in terms of major limitation of robotics remain the cost, and probably the introduction on the market of additional robotic manufacturer will drive down the costs, and probably robotic will be more economically feasible for surgeon. And at the end, laparoscopy represent an effective, less invasive alternative to open pyeloplasty. In our center, we perform open pyeloplasty only under 1 year of age. Robotics is technically easier, robotic pyeloplasty compared to laparoscopic pyeloplasty as for technique point of view, and as for robotic pyeloplasty probably will become in the future the new minimally invasive standard of care for children with UPJO, thanks to the precise suturing and the shorter learning curve. However, at the moment, if you have to decide, if you have a children with a UPJO, to decide to operate in laparoscopy or robotic, I think that you have to be tailored the decision on a specific case and on a personal surgical experience. Thank you very much.
Talk is for Allah. Allah, you have time.
Yeah. First of all, I would like to thank the two presidents, which are the both fathers of this masterclass, Philippe Montupet and François Becmer, and also our chairman. And it's a great pleasure and honor to make the ESPU share this great event with the ESPES and the IPEG. So after the presentation of my friend Ciro, it's always difficult to talk after him because it's a very nice and precise presentation that took nearly all the points. But if we go back to the history of laparoscopic pyeloplasty in children, we all know that it started transperitoneal in the 90s already with Craig Peters, and then extensively used by Hochtanz. And the retroperitoneal surgeon, they waited a few years before they start to adapt their technique with C.K. Young, first publication in 2000, and the same year with my friend here, Ois Diart and Jevala, the two centers published the first series in 2000. So it is now nearly 20 years, which means that 19 years that we are talking, we're saying that in the axis it's better retro or trans, the dissection, the working space. But honestly, after all the experience, we need to be familiarized and to master both techniques. Personally, I still convinced that in urology and in upper tract surgery, retroperitoneal space must be privileged whenever it is feasible and safe. So our current management for UPG obstruction in children for approach would be the lateral retroperitoneal laparoscopy, except for anatomical reason like ectopic pelvic kidney, horseshoe kidney, and rhinopyeloplasty would go through the peritoneum to do it because of the anatomical consideration. It's important that to master the lateral approach, retroperitoneal approach, to make it standardized for all indications of renal surgery. So, here, so the surgeon is always behind the side of the kidney to be operated, and all the monitors and everything is positioned in front of it. It's also important to understand the anatomy, where to open the gyrotis fascia, where to put the trocars. In the lateral retroperitoneal approach, it's important to go through the gyrotis fascia as far as possible very close to the psoas muscle to keep upscreen the structure. So, which we're going to see it with this opening of the gyrotis fascia in this way. In the lateral approach, we use 3 trocars. The main trocar is a 5 millimeter optic, 0 degree, which is the endpoint of the 12th rib, and then 2 operating trocar, each one 3 millimeter diameter. The axis is always the most problematic part of the retroperitoneal, and it's difficult to reproduce. So we go straight to the gyrotis fascia that you can see it here, the white, very strong fascia that you can get it out, and then you open it under vision, and then you introduce your trocar inside. In fact, in children, you don't need to insufflate with special devices to create the space. Here, in this case, you can see that in a 2-month-old girl, we will go through the same retroperitoneal approach. And when we go in, especially in the small children, we were surprised by the very nice space, and especially the accuracy of the visibility because lack of retroperitoneal fat. So in this case, you identify perfectly the structure. This is a huge renal pelvis here. The only thing that you operate very close to the structure, and then we insist to use 3 millimeter instrument, and especially bipolar instrument. We don't use any monopolar energy, as the intestinal loops are just behind the very thin peritoneum. The key point is to use the traction suture. Here we use a 5-0 traction suture. And the traction suture, the main benefit of it is the exposure, and especially not to manipulate and not to touch the suture, the structure that you're going to keep for anastomosis. So you pull on it, you define perfectly where you're going to start your incisions. Here you have the renal pelvis, the most dependent part. Upper screen is the lower pole of the kidney, because one of the disadvantages of laparoscopy, of course, the risk of twisting the anastomosis. And then you start to do the spatulation. You need to have a sharp scissors of 3 millimeter. The blade makes 1 centimeter of length, so you need 1 centimeter. We avoid all hemostasis on the edge of the cutting, and need to be one cut, and you keep in the same axis to avoid any spiral cutting and spiral spatulation. And then, as in all laparoscopy, you need also to use your both hands. So in this case, you shift the scissor to the left hand to be in the axis, which of course this would be totally avoided with robotics. And then here you will cut, again, a sharp cut, and you go as far as you want. But usually in laparoscopy, we don't do a major reduction of the renal pelvis. We just do it to have it as optimal as possible to have dependent anastomosis. And then, after defining the most dependent part, which is, I believe, the most important part of this surgery, is the localization of the site of your first suture. So as you can see that there is no hemostasis that is done. And then we use a 6-0 monofilament. Most important is that the needle is a 3/8 of diameter of circle, so it can go through the 3 millimeter diameter. And it needs to be precise, so like this in the axe, and then to make the suturing, and then we fix the traction suture in the psoas muscle to have a stabilized line of anastomosis. So tractions are important, not to touch the mucosa and not to touch the structures while you're suturing. We use the same stitch, the 6-0, and then we'll run the first line of anastomosis, which is here, is the anterior line of anastomosis, which is close to the peritoneum. And as you can see, especially in infants, I believe that it's important, as in open surgery, to use the no-touch technique. Even it takes you more time, but it will avoid complications after. When you finish, we use mostly now an extra stent, an external stent, which we use is a modified, what we call a blue stent or Pepicali stent, that we go percutaneously in the renal pelvis, and then we recover the guide wire and then the stent. We cut the lower coil of the stent not to go through the uretrovesical junction, and the upper coil, we will position it in the renal pelvis, and the stent will be placed in the ureter. And of course, the exposure is so good that you can really check that it is going well and not to go through the bladder. The bladder, of course, is drained by a Foley catheter during the surgery. And then we go through the posterior anastomosis with another new stage of 6-0. And finally, we dismember the UPG. We knot the two together. We always keep the two needles in case that one of the needle is broken, that you can continue with the other one, the running stitch on the renal pelvis. And to avoid also to restart another stage at this point, which is the point of leak usually. And when it's finished, we don't put any perirenal drain. And it's important, especially in infant, that you can see that the renal pelvis has not been mobilized. The ureter stay attached to the mesentery without any devascularization of the ureter. We have already shown that there is no difference between if you use this type of stent or a double G stent. It's only the anatomical difficulty to put it or not. So if we can put an external stent, we would do the external stent. So we have a global exposure with the retroperitoneal, also for the crossing polar vessels, or even for exceptional like a retrocaval ureter or any atypical anatomy. As for the crossing vessels, it is the opposite of transperitoneal, which of course it's more difficult than the transperitoneal to do it, but it is feasible. We keep it with the retroperitoneal. As soon as we catch the UPG, we start to free the anterior surface of the polar vessel, and then we start again the traction suture on the UPG. The only difference that you have, of course, you have to dismember very early your anastomosis, your UPG, and then after that you will continue as usual doing your suturing using the same stitches, and after that you fix to the psoas muscle. So like this, you will get it away from your crossing vessels while doing your anastomosis. And then your anastomosis, of course, the difficulty that you need to catch this part, which is going to be removed at the end of the surgery, and then again, you transpose totally your sutures towards the surgeon. So in this case, we would go. In this case, we would like to show you how we put our double G stent. So at the end of the first line of suture, we use the costovertebral angle 3 mm trocar, which is in the axis, and then we push the double G stent, while the guide wire is inside. And so like this, it's sometimes also, it's of course difficult to put the double G stent, and it's sort of trouble. That's why we are shifting more and more toward the external stent. the most important is at the end of the surgery, we are having a free polar vessel and a great space between the polar vessel and the peritoneum. Even with experience after, you go through the difficult cases like a left single kidney in this 14-month child who's having double-side stenosis, as we can see it here with the MRI. And in these cases, you can see the exposure again of these young children, especially, with that you can identify perfectly the vascularization to identify where is the double stenosis and where is the dilated. And in this case, we had the idea to use the middle segment, which is the dilated segment, to do just a lateral side-to-side anastomosis to keep this dilated segment to avoid replacement of the ureter, and then to go to the mid-ureteric stenosis to do the precise resection of just this part, which most of the times contains urethral valves also. So you can see that the vascularization can be kept till the end of the surgery after this anastomosis. In our first publication, we had the great news that with laparoscopy, retroperitoneal, that we can achieve at 98% of good result with only 2% of redo, even containing 30% of obstructive polar vessels. But of course, we cannot say that it's easy. It's very difficult, and it demands a lot of time and a lot of learning curve. In this publication here, we thought that after the first phase of 30 cases, we started only to include fellows in the training, which are the red spots, until the end, and no more conversion, and the redo cases is extremely becoming rare. In this, our first publication to compare our old results with operative time with open surgery. And of course, at that time, which is interesting, you can see 15 years ago, children were going out in open surgery at 5 days and laparoscopy 2.9 days. But if we have done this, which is not published yet, this data, but we presented at the ISPES last time, with that we compared our recent theories of children under 12 months of age to dorsal lumbotomy. And you can see that the operative time, even in this underage, is now 160 minutes, which is less than 3 hours, of course, but it's still 2 hours and a half nearly of operative time, which is exactly the double of the open surgery. Even with experience, we don't achieve comparative time. But what is interesting, that the hospital stay, even in open surgery nowadays, has been dramatically decreased. So the comparison with hospital stay is less significant. And I believe that it will be more and more significant. Why? Because of the progress of perioperative analgesia control by anesthesiologists. So it's very difficult to make it to make clear the advantage of 1/10. Where there is one only publication of randomized controlled study, prospective by Badawi in Alexandria, that he compared prospectively transperitoneal and retroperitoneal, and showed that in retroperitoneal there is earlier oral feeding, shorter hospital stay, and shorter even operative time for these children. Robotics, of course, it's not new. It's more than 10 years now. But our friend Thomas Blanc he's mastering the retroperitoneal laparoscopy, and then he started the robotics, and now he is using the robotics retroperitoneal access for laparoscopy, for pyeloplasty also. I just use nearly the same slide as my friend Chiro has shown, but in this it shows very well that children under 1 year, there is no progress, nearly no progress of robotics at all. You can see that the robotics is the green line, and it is so little compared to the adult and adolescent, especially adolescent pyeloplasty, which is in the United States becoming mainly robotic. But you see that the blue, there is nearly no progress in the rate of open surgery in the United States. Why? Because the robotic could not achieve this facility. There is another paper which is very interesting, came by the team of Aubert Lardy in Tours in France, with great experience in robotics. When you see the learning curve in robotics, you see that it is very quick, very fast. But his idea was original, which is the multi-outcome approach, which means that when can you say that I can teach the fellows, I don't have complication, I don't have conversion. And here we come, you need 41 cases to achieve mastery of the technique with robotic. So it's still robotic with pyeloplasty in children, still need, and this is of course transperitoneal pyeloplasty. So finally, laparoscopic pyeloplasty can be done transperitoneal, retroperitoneal. We did not talk about single port. It can be done robotically, but I believe really just to do it and do it well, and there will be no difference between the techniques. It's just to be familiar and master the technique. Thank you very much.
Thank you very much to the speakers, Chiro and Ala. Professor Ram is still online.
Ram, are you hearing us? No, we can start with questions.
Yes.
And Ron probably could hear them.
Is
yes?
he still online? Okay.
Okay.
Yes, yes.
Do you have some comment or personal questions?
Yes, Ciro and Ala, thank you very much for your excellent presentations and so an overview of where we are. Can I just start off with just asking Ala, because your presentation effectively says it takes a long term, it's much more difficult to learn retroperitoneal surgery. And given the era of robotics and majority of people performing the operation transperitoneally, my question to you is, why bother with retroperitoneal approach if there is no difference in outcomes?
It was just my first slide of my presentation. I don't think, Ram, there is a big difference, but I mean, go and tell somebody to go through the peritoneum to treat the kidney. I think when it is feasible, retroperitoneal would do it. And we just acquired a robotic, and I think that in our experience, we would go through retroperitoneal robotic for kidney surgery when it is feasible, which means that when children are elder and when they are young, I think there is still the place for minimal invasive 3 millimeter diameter until the development of a true pediatric robotic surgery.
But so you know very well that the skill, the skill mix of various surgeons varies. And so they will not be able to match your skills. So what's your advice to them?
Ram, can you repeat your question, because the level was too low?
Yeah, my question is, Ala, is that the surgeons laparoscopically do not match your excellent laparoscopic skills. So what is your advice to them in terms of learning curve and wanting to persevere with the retroperitoneal approach?
They just, I don't think that it is something which is exceptional. It's exactly like very complex reconstructive surgery in pediatric urology. It is just all our fellows that went out from our department in the last 10 years, they are now independent retroperitoneal laparoscopic surgeons. So it is just a kind of training and consistency. It's exactly, I don't think that transperitoneal is easier. It's also need skill, which are exactly the same things. I don't believe that any surgery need really a highly skilled man or anything. I mean, you can do laparoscopy when you have pains in your wrist joint or anything that you cannot do it in open surgery. So you don't really need skills.
Can I add a comment on this point? I think that laparoscopic and retroperitoneoscopic PLAplasty are advanced technique and they require an advanced surgical skill because you need a delicate suture and not easy to do. At above all, at beginning, you need 2-3 hours. I think that in this field, robotics has a huge advantage. I work in a training center in Naples and my trainees are able to suture in laparoscopy and in robotics, and the learning curve to suture in robotics is very, very quick. For this reason, probably I think that in the future robotic pyeloplasty will be the technique of choice because it's technically easier compared to laparoscopy and retroperitoneoscopy.
Okay, so that takes me nicely to the next question, Ciro. Is in your robotic program, on the robotic cases?
Please, can you repeat? We are only the first part of your questions in your robotic program.
Yes, so in your robotic program, what is the limit on age or weight?
Yeah.
Because both of you have shown the slides, and Allah has picked on it to say that the robotic cases under 1 year has not caught up with the older age group. So in your program, what is the limit of age or weight?
I prefer in the first year of age to operate infants using open surgery because it's so easy, I think. Between 1 and 3 years, I prefer to adopt laparoscopy. After 3 years, I prefer to use robotics because I think that at the moment, the main limit of robotics is the cost for sure, but above all, the diameter of instruments. The instrument we use with the XI is 8 millimeter and is so big for a young infant. For this reason, probably in the first 3 years of age, between 0 and 1 we use open, 1 and 3 we prefer laparoscopy, after 3 probably robotics is the best procedure to adopt.
Okay, one last question before Mario can ask the internet questions. Ciro, what is the advantage? Why do you have to put a drain?
Yeah.
You said you put a drain in. Why do you put a drain in?
Because I think the disadvantage of transperitoneal approach compared to retroperitoneoscopic approach is that you are in abdominal cavity, and sometimes you can have leaks of urine and can have a problem. For this reason, for security reason, I prefer to leave a drainage. You put the drainage to one of the trocar orifice, you can sleep well at home, and if you have no problem, you can remove the day after.
Your experience is not matched by your experience is not matched by literature, because literature doesn't say that there's extra complications from transperitoneal approach.
Yes, I agree with you. There is no evidence on this point. As for the cholecystectomy, we prefer always to leave a drain also after a cholecystectomy to sleep well the night of the surgery when we remove the day after.
No, but that's different from cholecystectomy because of bile.
Yeah.
Okay, we'll just pause for a second. And Mario, do you have any questions from the internet?
So far, we don't have any questions, and I take the advantage to encourage all the audience that please, you can participate, ask your questions. We don't have so far any question for the audience.
Okay.
I have one question.
Then I would, go on. Go on.
We have a second special guest. And it's my honor to present him. You know him. He's our friend Jeff Valla. And Jeff was advocated by Allah and a number. Are you connected, Jeff? Jeff is a professor in pediatric surgery in Nice. Okay, Jeff. And you were a president of IPEG and also a named member of ESPU. And you attended closely this topic with us. So probably you have a question and remark or comments. You can hear and speak to you.
Okay, Philippe, can you hear me?
Yes.
Can
Perfectly.
you hear me? Yes?
Yes.
Okay, perfect. So we are very glad to be with us today with my friend Jérôme Laurent et Pierre Alessandrini. And we are very interested by this master class. Even if today in Nice the sun is shining, it's a very good day for sailing or cycling. Nevertheless, we are happy to be with you in this dark room. Concerning the speak of Ciro, the main information for me are that still today the majority of cases are performed using open surgery. Of course, robotic surgery remains a dream for a majority of pediatric surgeons, but I am convinced that it is the future. Even if I have seen no major progress concerning the miniaturization and the cost since 20 years now. As said Ciro, I totally agree with you, Ciro. Before 1 year of age, open surgery by posterior approach is a very good option. Between 1 year and 5 years, I would say, okay for retroperitoneal laparoscopic, classic approach laparoscopic, and after, if you can use a robot, is a perfect indication. The main lesson that the robot now is good for the surgeon, for the pain of the back of the surgeon, but is not proved that the robot is better for the patients. Concerning the speech of Allah, you know that I agree with you. I do exactly the same than you, but I think that our technique is not reproducible by the majority of pediatric urologists. So before doing that surgery, you need a very long training. And you must accept to be tired after surgery and have pain in your back. I don't agree to manage the polar vessel by retroperitoneal approach, except in the same session, the junction. So I am ready to answer to your question. And thank you again for your invitation.
Yes. So first, Jeff, it's really a pleasure because you know that you are the one who gave me the virus of retroperitoneal. I got it there in Nice in 1992, which is now getting very old with it. It's nearly the same technique, but when we do the polar vessel, of course, we resect the junction. We resect totally, we totally resect the uretero-pelvic junction. We do exactly the same surgery. It's more difficult, that's right, but 30% of our patients, they had polar vessel, and we had already presented our study in the ESPU that we did not find any difference between if you have polar vessel or you don't have it as far as concerns the operative complications, post-operative complications. And I agree with you that it is not reproducible if you are not dedicated to it. Most of the people, they abandon retroperitoneal after 10 cases, 15 cases, and then they go to back to transperitoneal. That's right. Except, of course, these poor fellows who work in our department, that they are obliged to work with retroperitoneal for 2 years. So they are obliged. So in 2 years, they finish the learning curve and then become independent.
And the best example of that is Henri Steyert, which is with you, because in Nice he performed a retroperitoneal approach, and then in Bruxelles I think a transperitoneal approach, because it's more easy to learn.
Jeff, can I reply to your previous questions? First of all, it's a pleasure to see you, and we have the same feeling of a lot of things. I started to perform mini-invasive surgery about 30 years ago with Philippe Montoupé and Jeff Vallin in France. And I think that after about 30 years of experience, I think you have to perform a mini-invasive surgery technique that is easier for you and more reproducible. As for these three techniques, retroperitoneoscopy and laparoscopy are very good, but are difficult to perform, and you need a long learning curve. Of the contrary, robotics is very easy because it's easy to perform and easy to train, and then the trainees can train on a simulator. For this reason, they don't need to train on human model, they can train on a simulator. For this reason, probably for this kind of surgery, for pyeloplasty, the future will be for sure robotics.
I think that the future is for robotics also, but I would like to remind the pediatric urologist and pediatric surgeon that till today, after 10 years of development of robotic, we did not see papers coming from your department telling us that your fellows and residents are doing pyeloplasty much more faster and with publication. We did it in laparoscopy. We will do it in robotics because we just bought a robot, but I think it is a must that all the Department of Pediatrics to go further and tell us truly if it is faster, give us series, give us studies, give us results. So we need this because it's really easier. That's right, we feel that it's easier when we start, but reproducible.
Yes. Hello, Jeff. Happy to see you again.
Yes.
I had a question to the experts. Everybody is saying that under the age of 1, it's probably easier to continue it open. I don't know why. We published just very recently a paper about our experience in Brussels transperitoneally, and we have exactly the same results as in bigger children. And I think really that it's quite perhaps easier in little children than in older children because you see it so well, there is no fat, there is nothing. And Hala will also probably publish his paper retroperitoneoscopically under the age of 1, and he has the same results. So I don't know why the experts say under the age of 1, yes, do it open.
Henry, the problem is that these series are operated by experts, and I agree with you, under 1 year of age we can perform very well a UPG obstruction with laparoscopy, but is not very reproducible, and that's the problem with the majority of the surgeon. Henry, you are an expert, you know that, like me.
No, I'm not an expert. You are the expert, and you are saying that you do it open.
Thank you. We have a question also. Yes, we have a question from the audience. You want to answer again? Okay, we have a question from the audience. They're asking about leakage after transperitoneal approach. What is the rate and the management, according to your experience?
As for the rate of leakage, I think is less than 5%. The majority of pediatric urologists, pediatric surgeons prefer to use running suture. For this reason, the leakage is, you have a small leakage, above all because if you use a double J stent and then a Foley catheter in the bladder, the incidence is less than 5%. And not all pediatric urology put a drain. In my experience, I prefer to put a drain, but it's not mandatory to do it for sure.
Thank you very much. We have another question about your follow-up. How do you control your follow-up, and how often?
Yeah, may I start? For our protocol of follow-up that we do ultrasound first month, and then at 6 months, and then if everything is good, it will be annual until 5 years, and then every 5 years until puberty. Except if you have a differential function which is measured before the surgery, we would do a re-evaluation 1 year after for the function. But I think it's important to keep the follow-up until puberty.
Yes, the same. We follow these children with our pediatric nephrologists only with ultrasonography if they have no particular problem, with one echography at 1 month and then yearly until 18 years of age.
Perfect, thank you. I have a question also for you. Regarding re-ops for recurrence of the stenosis, in your experience, what is the place for retroperitoneoscopy and what is the place for robotic surgery for this case?
For the redos?
For redos.
Yeah, for the redos, for us, it's transperitoneal. Why? Because of when you do, most of the patients are coming after open surgery. And that's why I'm always surprised by that surgeon has forgotten that they have complication that we have to redo after open surgery. Everybody's saying that it's perfect and there is no complication. But us, we have complication with open surgery, and all our recruitment of cohort of redos is 80% coming from open surgery outside, and 20% is our own complication after laparoscopy. So when we dissect the retroperitoneal space, it's not reasonable to go back and re-dissect the space. In this case, we would go transperitoneal and to go directly to the UPG without dissecting the lumbar fossa.
Thank you.
Yes, I think that, as Ala said, in case of redo surgery, the redo pyeloplasty has to perform transperitoneally, and I think the best way to do it is robotics. So we operate Monday, redo robotics, and with the robot is very easy to dismount and to redo a pyeloplasty.
Oh, thank you very much. So we don't have more questions, and we conclude this session. Yes, Professor Subramani. Yes?
Yeah, just to reaffirm what Ciro has said, I think robotically to approach a redo pyeloplasty, even if it has been done previously by open approach, is the best way. The anatomy is much well defined, and it's much easier to perform an operation with a robotic approach. I thank everybody for all your efforts, and over to Mario.
Thank you very much. So we conclude the session. Thank you very much to the speakers and the participants.
Thank you very much to Mario and Ram and all the audience. Do remember, you are invited to chat with us during the last and third topic and for the session of questions. And this topic is introduced by our Space President Henry Steyert, and he is going to present his speakers.
Yes, and I hope that attendees will chat a lot for this last topic. So it's my pleasure to present first Arnaud Bonnard, who is the responsible of the Department of Digestive Pediatric Surgery at the Robert Debré Hospital in Paris. Every knows him.
Waiting for others to join.
He organized the 2018 very successful EUPSA Congress in Paris too. He is member of most of the pediatric surgery societies, author of numerous publications in the field, and he has something in common with me. We like together the city of Nice in the Côte d'Azur. It's also my pleasure to present Paul Philippe, who is the head of the Department of Pediatric Surgery in Luxembourg. He's one of the pioneers of minimal invasive surgery in pediatric surgery. He's doing everything, really everything in minimal invasive surgery, thoracic, abdominal, and for example, intravesical Cohen operation that he is still doing. And it's perhaps because he's living in Luxembourg, but he's also the treasurer of several pediatric societies, and in particular the ESPES one, and I thank him so much for that. So we have seen that in UPGO operations we are discussing about robotic, trans, retro, and eventually a little bit open surgery under the age of 1. But what about duodenal atresia? That's of course under the age of 1. And is it better open or better minimal invasively? So first to fight will be Paul Philippe to defend the open management of duodenal atresia.
Thank you very much, Henry, for this nice introduction. I would like to thank all the organizers, and especially Philippe and François, for inviting me. Microphone. So I would like to thank the organizers, especially Philippe and François, for inviting me in Strasbourg again. I would like to thank all the chairmen, and as you said, I'm the treasurer of ESPES. I would like to ask all the audience not to forget to join and pay their dues. All right, can I have the first slide? Now, I was tasked with something very difficult for me. Discuss open surgery for the management of congenital duodenal obstruction. And I realized that there is one big difference between videoscopic and open surgery. It's the lack of quality images. We have videos in laparoscopy, we don't in open surgery. Now, I come from Luxembourg, which is a small place very well known for this type of problem, but I do not have any conflict of interest. Just a few reminders about duodenal atresia. It's a rare anomaly, 1 in 10,000 births. It's rarer than many other problems. It is different from intestinal atresia, as this one is considered as a failure of the development of the duodenum. It is very well known for being associated with other anomalies, particularly cardiac conditions in 20%, other digestive problems like esophageal atresia in almost 10%, and it is extremely well associated with Down syndrome, trisomy 21, in 30% of the case of duodenal atresia, and 5 to 10% of the infants with this condition will have this. What is maybe less commonly discussed is the association with malrotation. And 20% of the duodenal atresia patients also have a malrotation. Most often the mistake is to forget the duodenum when facing a malrotation, but this is something that needs to be diagnosed and treated together with the duodenal atresia. Now, the preternatural conformation of the guts was described in 1773 by Mr. Calder. At the time, nobody had any idea that a picture could even be taken. It took 250 years to have the first survivor in 1916. And I just said that today, 95% at least of survival is expected, and the mortality is related to congenital anomalies. They don't die from their atresia, they die from their heart disease. Now, I found in this nice book from Bernard Duhamel in '53, this report of his experience on duodenal obstructions and stenosis, and I am not going to translate this column, and you see that only few kids operated later had a chance to survive, but that was 80% death. Now, why do we get esophageal atresia? Well, it seems that it is an imbalance between the development of the endodermal component of the gut and the mesodermal, the muscular layer, that ends up with a complete plug of the duodenum at the end of the 2nd month of gestation that will then progressively get recanalized. And that's the failure of this cord to reopen that leads to duodenal atresia, webs, and stenosis. Of note for the embryology, the pancreas most of the time is abnormal because the duodenum is abnormal. There are several hypotheses that is a big topic in research, like the role of the fibroblast growth factor 10, very common for us surgeons, or the signaling between the different embryonic layers, but I will not spend a lot of time on this. It's easier for surgeons to see the picture. This is a normal recanalization. This is an incomplete recanalization that will lead to web stenosis. And this is a failure of recanalization, that's an atresia. So this is an organogenetic dysfunction, to the contrary of the classical alleal atresia, where it is a post-conception antenatal ischemic event that is suspected to be the cause of this. Very quickly, we know how the diagnosis is made, antenatally and postnatally, with a double bubble, full of liquid in one, full of air in the second. On both, it's black. We know that the workup is usually made on plain X-ray, and the first contrast to use is probably simply to inject air in the tube. We know that a plain X-ray can differentiate different type of atresias. And our main concern would be this type of case where there is a nice double bubble, but also air distally. And here we have to ask the question, is this a diaphragm, an incomplete atresia, stenosis, or is there malrotation? And probably those cases are an indication for upper GI contrast studies. Now, more interesting, because when we are going to operate, we need to be aware of that there are three types of atresia. Type 1 from Gray and Skandalakis is two ends in contact with a continuous muscular layer, sometimes an incomplete closure, as this demonstrated is. That's 90% of the atresias. In 80% of the cases, the bile ducts enter the duodenum at the level of the proximal pouch that will make bilious vomiting. In 20%, it enters lower, and then the vomitus will not be green. This is the rarest form with a cord between the two segments, and this is a form that can lead to surgical problem, to identification of the distal end. That's the type 3 with no connection. Now, once again, the annular pancreas is a different issue. What we need to remember is that it is mostly secondary to an intrinsic duodenal problem, as that dividing the pancreatic tissue not only will not solve the intrinsic problem, but will also risk to hurt major pancreatic ducts. Now, how do we repair duodenal atresia openly? We need a limited right upper quadrant transverse incision, as shown here. We would use a small one and extend as necessary. And in most of those infants, it is quite possible to bring the duodenum almost out. As mentioned before, the first step will be to check for malrotation. Remember that lats band by themselves rarely cause a very significant duodenal obstruction, and that most commonly it will be associated to an intrinsic duodenal anomaly. So if you do the lats procedure alone, you need to confirm that the duodenum is patent, and the best way is to take a fairly large NG tube and by hand advance it through the pylorus to the end of the duodenal jejunal junction. Now, once you have solved the problem of malrotation, the first step will be to mobilize the hepatic flexure to gain access to the first and second part of the duodenum, and then to do a Coker maneuver in order to have a good mobilization of the duodenum. And then it would almost come out in the field, and most of the operation could be done outside. Now, what is more difficult is to find the distal stump if it is not in continuity with the first one. You can often find it by simple dissection, but if it is a bit further, a good way to do it is to mobilize completely the primitive bowel loop, as you would in a malrotation, flip it to the left side, and you can even free the attachment of Treitz ligament to the first jejunal vessel in order to bring the distal duodenum close to the proximal one. The next step, often forgotten about duodenal atresia, is to check for a second atresia. This is, oops, I'm sorry. PowerPoint just quit, it's restarting. I hope. Is it okay? Yes. So we've... Wait.
This is because he's presenting open surgery.
Absolutely. All right. So we say check for a second atresia. We know that in ileal, but we forget about it in duodenum. Now, this is, for instance, a cohort study published by the team in Toronto, where they had 140 patients with duodenal atresia. 7% had a second location for obstruction. Now, it is interesting to analyze it a little bit. 4 were in the duodenum itself. 3 were apple peel atresias, which could be volvulus from malrotation. And no one of them had trisomy, which would lead to a suspicion that this is a different embryological genetic issue. Now, a couple of case reports where you can see here, if I could find here it is. Here, the duodenal atresia and the apple peel, the typical apple peel. Here, the cul-de-sac of the proximal duodenum, a second part, and then a second atresia. So, to deal with this, what we do in open surgery is to put a tube in the distal duodenum and distend it with saline until we can confirm that it reaches the distal part of the colon. And I think Arnaud will tell us how to check that in laparoscopy. What is interesting is that because this problem is often underestimated, in this meta-analysis, they found that it's almost 3% of associated atresia, and that the second atresia can be missed in 1% total, 0.3 in open, so if you don't look for it, you may miss it, but 3% of the atresias can be missed with laparoscopy. Now, the oldest technique for the repair of duodenal atresia, because it was fast, easy, and reliable, was gastrojejunostomy. This is just one example of what it looks like. It has been abandoned because of anastomotic ulcers, neoplasia, poor function, patient discomfort, and so on and so on. Now, the next repair, as described in this book from Pellerin, is the transmesocolic duodenojejunostomy. It is also quite easy to do because there is almost no mobilization of the bowel necessary. This is the one that gives the poor reputation of duodenal atresia as far as delayed possibility to refeed the child, the delayed function. It also leaves a long segment of bowel out of the loop, and this can cause blind loop syndrome. So the most logical repair is to connect the duodenum with the duodenum. Here again, Pellerin suggested end-to-end anastomosis, which is quite difficult because of the difference of caliber and the difference in mobilizing the duodenum that is stuck to the pancreas. So the bypass procedure, where the obstruction is in fact not removed, by the duodenostomy, side by side, lateral, has become the standard. And initially it was done by opening the two parts and closing side by side, which means that the most distal part of this enterotomy was sutured to the most lateral part of this enterotomy. This led to delayed opening and delay in refeeding. It's in 1977 that Kimura in Kobe, Japan, described for the first time the diamond-shaped duodenostomy. In his initial paper, 6 of the patients were neonates, because occasionally a child with a stenosis will come up later for his surgery. All the kids were fed within 3 days, relieved of intravenous support within 6 days, and that was done at the time where the duodenojejinostomy with a gastrostomy was still the standard. They followed up 15 years later with late results. There again, on 40 patients, the mean start of oral feeding was below 4 days. The infusion was stopped at the end of the first week. And at long-term follow-up, all were free of symptoms, normal weight, and perfect barium studies. So the diamond-shaped duodenostomy has nowadays become the gold standard for the repair of duodenal atresia. What about the web? There are 2 issues when we discuss web or diaphragm. One is, where does it come into the duodenum? You have very nice cases where the disparity in diameter is at the level of the web, but you have the famous windsock deformity, where the occlusion is in fact at this level, but because the mucosa gave and came into the lumen here, from outside you would think that it is at this level. And the risk is to do your anastomosis between here and here without actually opening the proximal lumen. You should open right there. So how can you do that? Well, move the tube, the nasogastric tube, through the pylorus and push it down. Use a tube that is not too little, and moving the tube through the pylorus is so easy with your 2 fingers. Arnaud will tell us how we do it in laparoscopy. And then once you have opened the duodenum, confirm that you can actually see the tube in the lumen that you are going to suture. The second concern with diaphragms and webs is the biliary tract, because the biliary tract can enter above, below, or right at the level of the web. There are many variations. It can also enter in the pancreatic duct with a minor and a major pancreatic duct above and below the web. So when you will choose what you want for repair, you need to be aware of that. The web excision, which is making a longitudinal opening across the site of obstruction, resecting the membrane, needs to be sure that you will see the papilla and preserve it. And sometimes it runs within the web, and that could be very difficult. And then you would do a duodenoplasty by closing the duodenum transversely. One of the options to avoid all those headaches of the biliary tract is just to do a diamond-shaped anastomosis between above and below as a bypass. Now the The other issue that I think laparoscopy will not solve but will remain a question is, what tube do you need? These are drawings taken from Pellerin, a textbook of pediatric surgery technique in '78, and you can see that all of them have many tubes. Almost all newborns that had operation at that time got a gastrostomy. Now, many publications have confirmed that not only does it delay oral refeeding, but the presence of a gastrostomy is fraught with complications. So nowadays, it's fair to say that a gastrostomy should not be performed except in exceptional cases. Which is more debatable is the need for a transanastomotic feeding tube. At the time of gastrojejunostomy, as is shown here, we expected a delay in the oral intake, and we were at a time where intravenous support was quite difficult. So it was reasonable to think that we could start feeding quicker, but in fact, comparative studies have shown that it delays the start of oral feeding, it increased the risk of anastomotic leakage and the risk of stenosis. So nowadays, what we do, we put a nasogastric tube alone, no transanastomotic. We leave it under gravity drainage for the first couple of days. As soon as the amount decreases, we elevate it and we start trophic feeding, which is 1 or 2 milliliter of feed per hour. And as soon as there is no more aspirate, we start increasing the feeding. And usually the feedings are started at the 3rd, 4th, 5th day and is complete at the end of the first week. During that time, we use parenteral nutrition, but I call it economic, which means that all we expect is that this will maintain the metabolism of the child, but we do not expect to promote growth with it in order to avoid complications. Now, there are late complications for this. The most commonly described is megaduodenum. Megaduodenum is a huge distension, as you can see in this. This was 15 years after the procedure in a case from Toronto. There has even been a case recently published of a 59-year-old man having problem with this. What is very important to realize is that this is not a stenosis of the anastomosis. This is a decompensated muscle of the duodenum. That's a hypoperistaltic duodenum. And from the paper of Hein, redoing the anastomosis is useless. What you need to do is taper, decrease the caliber of the duodenum. Now, is that a case to do it immediately at the first operation? In series studying late outcomes, the need for redo because of megaduodenum remains in the range of 1 to 3%. The tapering can be done either by simple plication or by excision and suturing. Almost the same choice as with megaureters. So at this time, we don't do tapering initially, but if a revision becomes necessary in the years to follow, redoing the anastomosis is not sufficient. You need to have a tapering of the duodenum. Studies about the best technique, well, Weber on 45 case comparing duodenojejunostomy, side-to-side duodenostomy, and diamond-shaped duodenostomy, found a significantly shorter delay to postoperative oral feeding and to postoperative stay in the hospital. To the contrary, the team from Toronto very recently published a comparison between duodenostomy without confirmation of what type it is, and duodenojejunostomy, that's a recent current series, their surgeons believe that whenever it's a bit difficult to find the distal part, they will do a duodenojejunectomy, and they found, with a follow-up of only 6 and 7 months, no difference in the time to full feed, in the hospital stay, and they had no cases of blind loop syndrome from the duodenojejunectomy, but with a maximum follow-up of 2 years, which is probably quite short. So if I can say what open surgery can achieve, and laparoscopy must get at least similar result, is a survival of over 95%, exceptional anastomotic leaks that would lead to significant problems, very few early reoperation, a few late complications that might require secondary surgery later. And what I hope Arno will prove to us is that no new problems will arise. This study is, for instance, about the associated atresias. In this meta-analysis, almost 3% were found. 1% was missed during the first procedure. This was 0.3 with open and 3 with lap procedures. And if we go to minimally invasive treatment, in some web, is there a role for endoscopic resection of the webs? That's just a question mark. Thank you for your attention.
Thank you, Paul. May I remind the audience that you can chat with us through the internet. Don't hesitate to write your questions, please. And now it's the turn of Arno Bonnard for the minimal invasive approach.
So first of all, I would like to thank Philippe and François for this kind invitation to IRCAD, which is always a great pleasure to be here. And I'd like to thank also Paul, because he said already a lot of things on duodenal atresia, and I'm going to try to ask to his questions about how to look for associated anomalies, associated atresia, and how to open the duodenum at the good level to avoid to miss the duodenal web. So I will go very quickly on these general considerations because Paul talked about this very largely already. And you know that it's often diagnosed prenatally. It's not an absolute neonatal surgical emergency. And you have to plan, and you have the plenty of time to plan the surgery and the time to do during a day shift. Hopefully, you don't need to operate this baby during the night. And it's sometimes challenging because you have to remember that in case of duodenal obstruction prenatally, the baby is vomiting and you have a very large quantity of amniotic fluids, and this can provoke prenatal delivery. And some of these babies are very, very small, about 1,000 grams, and sometimes you have to operate on this very little baby. Sometimes, as Paul said, in 20% of duodenal obstruction, you have an associated with malrotations. You have to check this where you're doing the surgery and when you operate these patients. So this is the typical double bubble as Paul showed already during the second trimester, and amniocentesis has to be done to rule out trisomy 21 or Down syndrome. So it's the postnatally X-ray showing a double bubble, which is sometimes very rarely the diagnosis is done during the first year of life, and especially for patients with trisomy 21. And it's most of the time due to a web and a partial web, which provoked some vomiting, chronic vomiting, and failure to thrive. And in these cases, you have to operate on larger and older patients. And it can be sometimes difficult because you have air in the small bowel, and which makes the surgery sometimes difficult to get a good surgical space to operate. So talking about the laparoscopic surgery, it's sometimes, as I said, you have to operate on very small baby, about 1,000 or 1,500 grams. So you have to secure your trocar, and you can do that using a silicone catheter around the trocar, or you can use the Rotaloc trocar of 3 millimeters. And so you will be able to operate without repeat dislodgement of the trocar. So I used to place the patients at the end of the tables or cross the tables if the patient is very small, but it's usually the case because you operate on neonates. And I like to keep the legs dangling at the end of the tables, instead of putting the legs at the frog position. You have to deal with the anesthesiologist and make sure that they have all the access necessary to the head of the patients if they need to either control the tracheal tubes or control the nasogastric tubes. For the optical ports, I use the 5 millimeters and 30 degrees. And because of its neonates, you must avoid to go through the umbilicus, because the risk of injure the umbilical vein and provoke CO2 embolism is very, very high. So you have to go either below, but you have the urachal duct, so you have to be careful, or most of the time you can go on the left side of the umbilicus to avoid all this stricture. I'm using 8 to 10 millimeters of mercury of insufflations, but you can use 8 millimeters is usually enough to have enough space to operate, because for these patients, because of the duodenal obstruction, the small bowel is done inflate, and the small bowel is flat basically, and you can have a good space to work. The clue of this, I think the clue of this duodenal atresia repair through a laparoscopic approach is the stay stitches, and is the dissection of the duodenum, and especially the distal part of the duodenum. As Paul said, we have to make a Coker maneuver, and you can't basically make free the threads angles using this dissection, and then you have to expose your anastomosis with the stay stitches. Should we do a diamond shape anastomosis or a side-to-side anastomosis? Paul demonstrated already with the open approach that the diamond shape is probably the best anastomosis to do where you operate these patients with using an open approach. Using a laparoscopic approach, it can be challenging to do a diamond shape anastomosis, and it's sometimes better to do a side-to-side anastomosis. Claesbach described this and published this already at the end of the 90s, and it was the first who performed the duodenal obstruction, duodenal atresia using a laparoscopic approach, using a side-to-side anastomosis. He was using interrupted suture, and because of the high rate of leakage, David van der Zee stopped to do laparoscopically, and then he restarted a few years after using a running suture and without any more complications. But he's doing a side-to-side anastomosis. So it's the case on a very small baby. As you can see here, it's 1,500 grams. So first of all, you have to deflate the stomach here and ask to the anesthesiologist to put an NG tubes in and to deflate the anastomosis. The first stay stitches you have to use is to suspend the lever. And I used to take 2-0 or 3-0 stitches. in order to make sure that you will not injure the umbilical vein. Here is the things you have to see when you're doing the dissection. I'm just going a little bit back. Here it is. So when you're doing the dissection, you will be able to find the proximal duodenum just right there. It's obviously dilated. You have the annular pancreas here, and you have the distal part of the duodenum just right there. So you have to do a duodenostomy to bridge this part, the distal part, with the proximal part of the duodenum here. And to make this, you have to make the dissection of the distal part of the duodenum. It's basically the same maneuver you're doing when you deal with malrotations. So you release all the adhesion of the distal part of the duodenum, and you will be able to make free this distal part of the duodenum. So I'm using the bipolar, but now for this patient. But now we have the chance to have the 3 millimeters thermofusion device, which is make the dissection a little bit easier. So you have to be careful with the pancreas here, and so you make the dissection of the distal part of the duodenum. To identify perfectly where is the web or where is the atresia, you can ask to the anesthesiologist to push the NG tubes, and with the graspers you can push the NG tubes through the duodenum and to identify perfectly where is the atresia. Then you're using stay stitches to approximate the distal part of the duodenum and the proximal part of the duodenum. Here is the distal part of the duodenum has been fully released, and then I'm using these stay stitches to make the distal part of the duodenum and position the distal part vertically. And I will doing the same exactly with the proximal part, and I would use the stay stitches here to also position vertically, and you just have to perform the side-to-side anastomosis after, starting by the back wall and ending by the anterior wall of the duodenum. This way, you will be sure that you will not injure the biliary tract and the ampulla. I'm not very confident when you're suspecting where you have a web. I'm not very confident to open the duodenum and trying to resect the web and open the web because of the risk for the ampulla injuring. So I'm always doing a duodenostomy, even if it's a partial web or a complete web. So I'm opening now the distal part of the duodenum. The proximal part has been now positioning vertically through stay stitches. So I'm very comfortable to do the anastomosis here. The back wall is just right there and here. And I'm doing interpreted suture, but you can use a running suture if you want. V-lock is a good stitches to use it if you're doing a running suture. I'm using a 5/0 Vicryl with a 3/8 semicircle needle, which is going through the 3 millimeters trocar without any problems. So I'm using, as I said, interpreted suture. So you're starting by the back wall, and then you ending by the anterior wall. At the end, you have to check if you have any atresia associated, as Paul said. So you have to look all the small bowel using your grasper, and starting from the first jejunal loop and going down until the last ileal loop. Make sure that you will not have any small bowel atresia associated. It's sometimes difficult to rule out perfectly at 100%, especially if it's a web. But most of the time, you can do it just running, going up to down, all the small bowel to avoid and to rule out any associated atresia. I must admit that I'm not doing for all 100% of the patients, and I'm just doing this for this small baby, for example. I'm not running all the small bowel because I'm afraid I want a short operating time, and I want to be sure that I will not injure the small bowel. So at the end, I leave the NG tube in the stomach. I'm not doing a transanastomotic NG tube, so I just leave the NG tube just above the anastomosis, and I'm releasing the stay stitches. So the patient, basically, I must admit that I was very disappointed with the results of the duodenal atresia using an laparoscopic approach. And the patient was keep NPO until the first bowel movement, and we're trying to start the first feeding very early, and especially using trophic feed as we using the trophic feeds for the patients with gastroschisis. And we failed, basically, and all our first patients we operate using this technique were reached the oral feed and the full oral feed very late, and basically without any difference with the patients operate openly. So I used to, when the patients attend the postoperative day between day 8, day 10, I used to do a contrast study, because the contrast study is, I found, it helped the patients to recover quicker on the bowel movement, because probably of the effect of the contrast product, and something is creating like a flush through the anastomosis, and most of the time after this contrast study we will be able to advance on the oral feeding. But if we look at our results, and our first results we published in 2014, basically the duration to reach the oral, I don't see. I'm sorry, it's too small for me, but yes. I'm getting older. Oh, thank you very much. So the time to reach the oral feed was not very good, and as you can see here, the use of parenteral nutrition for all the patients was about 90% of our patients, and the median time to initiate the oral feeding was 8 days, and the median time to full oral feeding was 36 days in median. It was 6 days for one and 17 days for one because of a leakage. So basically our results was not very tremendous. So we look for another things. So I went through the literature and looking for advantages or disadvantages of this minimal approach. And so as I said, the laparoscopic repair of duodenal atresia was first published by Klaasbach in 2001, and Steve Rothenberg published also his paper in 2002. But if you're looking for advantages or disadvantages between laparoscopic repair versus open repair, as you can see here in this meta-analysis published recently in 2017, there is no more advantages to use the laparoscopic approach because of the time to reach the full feed and the time to discharge the baby at home. So I was a little bit disappointed, and I looked for another way to operate these patients. And thanks to this device, it's a 5 millimeters laparoscopic device, and we use now this laparoscopic stapler 5 millimeters to do the anastomosis. So we did this. We did this study with Philip, who is here, and Steven Rothenberg, and we report our preliminary results on laparoscopic stapler duodenoduodenostomy for duodenal atresia. And we look for the time to full feed and the time to discharge the baby. So the technique is always is the same in part of the dissection of the duodenal atresia. So we're using the 3 millimeters thermofusion device. So the movie is accelerated, yeah. Obviously. So the proximal part of the duodenum is just over there, and we have to release the distal part. So we're doing this using the Coker maneuver. So it can be done very easily with this kind of device. So the Coker maneuver allows to mobilize all the duodenum, the distal part of the duodenum. And then I used to approximate the distal part and the proximal part of the duodenum. I'm going a little bit faster. So the distal part is mobilized, and then we approximate the proximal part and the distal part of the duodenum. So as you can see here, it's side to side. So I open now the proximal part of the duodenum, and then I will open the distal part of the duodenum. We can already talk about to taperate the proximal duodenum. Because you have this 5 millimeter stapler, you can think that you can use it to taperate the proximal duodenum. But we try to do that, and basically the 5 millimeter stapler, it's not very adapted to taperate the duodenum, because the duodenum is very thick, and the 5 millimeter stapler is not working for that, and we have a leakage on it when we try to do that. So when the both parts are approximated, the proximal and the distal part is approximated, I use the 5 millimeter stapler. I'm staying very on the anterior part of the proximal duodenum to avoid any biliary tract injuries. And using this, you can make a very, very wide anastomosis. And then just have to close this here using interpreted or running suture as you want. And it makes the surgery quicker, easier, and very satisfied regarding the anastomosis, which is very large here. Looking for the results. So we have 16 patients already with Philippe and Steve. And as you can see, the midway diet surgery was 2,500 approximately. The mean operative time is 62, so it's just 1 hour. So and 25 minutes for one of the patients. Obviously, it was one of the Steve's patients. Mean time to first feed was 4 days, which is very different from our previous series. And mean time to full feed is 9 days now. So we will be able to discharge the patients about 10 days after the surgery and 8 days for one of the patients. We have one complication. It's on my last patients. We operate on 1,200 grams patients. We're doing this. And we have one complication with the perforations at the tip of the stapler. And we redo the patients because he presented 2 days after with the pneumoperitoneum. So we back to the OR with the patient just to close the hole. So the laparoscopic stapler anastomosis for duodenal atresia seems to offer better results in terms of time to reach full feeds and time to discharge. It might be in part be related to this wider anastomosis, and obviously we need long-term follow-up, and larger numbers are pending so far. Thank you very much.
Through the internet, and there are 2 questions. One from Dr. Alejandro Peñarrieta, and the other one for Martin Smek from Bratislava. It's about open surgery, but also about the anastomosis. And if I may, I can make a joke a little bit. Diamond-shaped anastomosis is mandatory here in the IRCAD, because you know that the IRCAD is just a training center, like a diamond is just a stone. So that's why we have to do probably diamond-shaped anastomosis. But the stapler is perhaps also a good option. The idea is to have as large as possible anastomosis, probably. And so the question is, why not doing that through the Bianchi incision, transumbilical? It's a good option. And the other question was, why not more than 4 centimeters? Because if you have to look to all the loops of the intestinal loops, 4 centimeters is perhaps a little bit too less.
Well, I think the transumbilical route is efficient in many, many infants. If you find a straightforward problem inside, it has been published. It's a route that I'm not very used to do for this. But if we can do pyloric stenosis, we can certainly expose this as well. I find the subcostal, the transverse subcostal incision, just because of the comment of the second comment, that's an incision that you can extend as necessary. You start with a little one, and if you don't see clearly, if you face a problem that you cannot solve, like a second obstruction, yes, you can extend. Now, when I fill the valve, through that incision, you can, for instance, you can grab and see the sigmoid column. And basically, if you see fluid through the sigmoid column, it is unlikely that more distal there is a problem.
So another question from internet, saying that the side-to-side anastomosis is used widely by a lot of surgeons, and it's probably, is there really a difference in the literature between diamond-shaped anastomosis and the side-to-side? I don't speak about open-off minimal invasively, but is there a difference between the results of these two anastomoses, or can we do whatever we want?
I could not find one study comparing directly the two. The most recent study was the one from Toronto comparing duodeno-duodenostomy and duodenojejunectomy, but they do not specify what type of duodenal anastomosis they do, and they found no difference. The only paper that really states a difference is the one from Weber that I showed, for which there is a significantly p less than 0.05 in both. And that's on a limited number, like 45 patients in total. So a good prospective randomized study I could not find.
And Dr. Bonnard, minimal invasively, are there papers about diamond-shaped anastomosis, or are they all done side to side?
It sometimes is not specified in the paper. So they're just doing we're doing a duodenostomy, and I couldn't find any paper specifically on diamond shape using a laparoscopic approach.
Let us then speak about.
If I may, I think that technically it is not much more difficult. The suture comes just as easy one way or the other. So if there is a chance that the diamond works faster.
Even minimal invasively?
Yeah.
But I'm here to defend the open. But, but yes, I didn't find any problem with doing diamonds in laparoscopy.
So, but I think that one of the main things we have to learn from this topic is probably your experience, Arnaud, about this stapler use that makes the anastomosis wider. And probably this is one of the lessons. We have to make a wide anastomosis. Yeah. Whatever the type of anastomosis we do, we must have a large anastomosis. Yeah, of course. Miguel.
No. Thank you. I just would add something from my very good old friend Arnaud. That I need to argue what you said, because you said a little thing that if a lot of people is hearing that, I don't know, is sure that you said it worked for me better doing the stapler than the anastomosis. and the patient get better faster. And I think definitely it's not the stapler. I think definitely is how, and Ray said it, that is your wide anastomosis. Obviously, it's much easier to get a wider anastomosis with a stapler, and it's much faster. But definitely, if you do a nice surgery with a very wide anastomosis, it won't change your outcome if it's a stapler or not. That's for sure. And in regarding the diamond shape or the side-to-side anastomosis, again, if you can manage to do a very nice wide anastomosis side-to-side or diamond shape, sure it will come out exactly the same. The thing is that sometimes you don't do that, and you have to have the time. And if you do laparoscopically, and we're doing this for a long time, definitely it's not time consuming when you have trained in doing that. So definitely, as Henry said, the size of the anastomosis is the key point of all the outcome with these patients, definitely.
I fully agree. I fully agree with you, and it's probably because my anastomosis was too short, basically. And it's a very important message from this. It's the message is don't be afraid to do laparoscopically. My results and my paper is probably due because my anastomosis was so small, and I fully agree with that. And so, don't be afraid to do laparoscopically. It's only a question of how you will be able to widen your anastomosis.
Can I say another thing? Sorry.
Of course.
That somebody asked about the umbilical approach.
Yes, Bianchi.
And so sorry for saying that, but I think a lot of us will agree that we're doing the one we did a long time ago, the pyloric stenosis through the U-shaped umbilical approach. It's horrible. It's horrible. Everybody gets in trouble putting things in there. Yeah. And you have to enlarge and you struggle. So if you're doing laparoscopically, fantastic. If you're doing open, do an open surgery. Don't do a little thing during the umbilicals, but you will run into trouble in 50% of the patients. So do it a proper surgery, even open, or even it's laparoscopically, but do it well.
Other question from internet?
It's not because it's hard to do. You don't have to do. Yeah. And I'm very big fan of the umbilical approach. We're doing for all the small bowel atresia and all these kind of things, and it's. You're right. Sometimes it's very hard to get back the small bowel in the abdomen, but it's not because it's hard to do. You don't have to do it. I mean,
I'm saying directly for the duodenal atresia. For any ileal atresia, it will come out perfectly.
You can do my rotations.
It's very, very difficult doing through umbilicals. That's why. But I agree with you. Yeah. All the rest is video-assisted surgery is fantastic.
Before your question, a question from internet from Dr. Askanani. I hope I spell it well. He asked a question about the weight of the patient. Is there a determinant factor to use the stapler anastomosis? Is there a weight, and we give the
on the last case? On the last case we've done, it was on 1,200 grams, and we made a perforations of the duodenum with the tip of the stapler. So I don't know. It was not clearly. It's a problem of the surgeons, and it's not a problem of the weight of the patients. So I will. If I have another cases, I will try
it again.
Yeah, I'll do it again.
So response is there is probably no limit, but you must be careful, of course, with the instrument you use.
Exactly.
So and then there is no discussion again about running suture or interrupted suture like in the Klaas Bach's papers. I think again, because I looked with David van der Zee to the videos from Klaas Bach's and then from David van der Zee, and the difference was the same. The length of the incision in the second paper, in the second series, the incision was longer because they were more able to do minimal invasive surgery, and they used interrupted suture because it was faster, of course, and they had better results. But it's probably not due to the running suture, but due to the largeness of the incision. Yes, question.
I just wanted to comment on what Miguel said about the width or the size of the anastomotic opening. I absolutely agree that this is key, and it does not necessarily depend on the approach or the surgical technique, whether to do a diamond shape or side to side or using the stapler. However, the stapler, as it has a defined length, which you have to be, which you have to bring into the lumen of the duodenum, defines also the width of the anastomosis, so it makes it much easier. And on the same time, and that's according what to Arnaud said, it saves a lot of time. So in conclusion, I'm not completely without any respect to the surgeon advocating the stapler, but it might facilitate the operation.
I completely agree with you, completely.
But again, it's also a cost issue using the stapling device.
Yeah. Yes, Paul?
About the stapler, I think it's important for the audience to realize that this was the 5mm stapler, which is not yet widely distributed, widely available, and that it's probably not wise to use a 12mm stapler and try to repeat it.
And to remember too that a 5mm stapler is probably can be used in high-level countries because it's very, very expensive. Yeah. So we have to say that too.
But it should be distributed now worldwide, so it should be available in every country.
But it does not prevent to get a proper training in minimally invasive suturing in small spaces.
No. And that was my next question. In UPGO, you have a lot of UPGOs. So you can probably train a lot with your tutor, robotic, retro, or trans, because there are a lot of cases, and you can do part of the operation, and then little by little all the operation. In duodenal atresia, it's much more difficult. So there is probably an absolute need to go to the lab and to train duodenal atresia on artificial models. Is there some progress in this field? Do you know something about that? About models, about 3D reconstruction of a little bowel that you can train on?
Everybody knows the model developed by Marcella Bailes in Argentina, and I think it's a perfect. You have it.
We will have it
okay.
Next week.
Okay, so it's a perfect model to train, and it's the only model I know regarding the duodenal atresia. We don't have any. I'm not aware about 3D duodenal atresia.
And this can be both?
Not at this time. But you can go and train with them. Or an IPEG.
Okay, so there's really something that we have to think about, because people has to train before they go to that, because this is really expert operation. And so you have another question about tapering. Sometimes it doesn't go well. And then we are there with this huge dilated bowel, still dilated. Do you never do a tapering anymore? Do you do sometime a tapering? And if you do a tapering, do you try it minimal invasively or not?
Initially, sorry.
Arnaud.
Well, I never had to do one, neither during my training, neither open, neither minimally invasively. If I had a case that I feel needs it, yes, I would do it minimally invasively.
Yes, the same reference. But initially, I never done.
And you had never a case where you had to wait so long that it was needed? No.
I have one case, yes, who has been referred to our center with duodenal, proximal duodenal dilatations, and he was needing a tapering. He was 7 years old, and he was vomiting, and it's the only case. And I have the impression that we have less and less patients who are needing a tapering. And I was trained with Yves Egrin, who write and who advocate the tapering initially for this kind of patients. And I've never done initially, so I don't know what's going on now.
Henry?
Yes,
it's impossible to know which patient will go good or bad with duodenal dilatation.
Yeah.
And most of them will get along if you just wait. So the advocate is not doing nothing at the beginning, because as you can, if you mainly we can see laparoscopically, you can see a huge dilated bowel duodenum that will work at the third day. Or some of the cases you have a mild dilatation and you have to wait 10 days. So it's possible to know in advance who will work longer or not. So as Arnaud, I won't do it initially at all.
Okay, thank you. Yes, last comment from Paul.
In the literature, basically, there is no way to know when you do it primarily if it was helpful or not. But most of the cases of tapering that we find in the literature are for late presenting cases. Yeah. Arnaud mentioned 7-year-old. I showed you images of 15 and somebody of 59. There is also a paper where in Finland they did upper GIs in everybody, 19 patients, 25 years and more after. All of them have abnormal duodenums. But they do fine, they have no complaints.
Okay. Thank you so much for this interesting topic, and we learned a lot. So I give last words to our masters of ceremony.
Thank you, Henri. We enjoy your last topic, and I have a few words first to thank the wide attendance on this streaming. And I remind you, last year we were more than 1,000 in a live connection for this streaming last year. Then I would like to thank our chairman and speakers, because it was a very, very interesting participation, very dynamic and excellent talk. Thank you very much. After that, I would like especially mention the kind help and support of the team of the IRCAD, especially in the room, Carlos Alves and David from the audiovisual team, and also Thomas Parent and Mireille Brown from the administration of IRCAD, and Margot Diebold and Isabelle Busser from the services of communication and course management. So we were very happy with this session, and that is due for the third time to two main personalities of IRCAD, who are François Beckmer, my friend, and thank you very much. It's a lot of work, and you are not full-time at the IRCAD also, so thank you very much, François, and Jacques Maresco offer many occasions for pediatric surgery to be present on the most modern streaming and organization of teaching, and thank you very much for your help. Thank you.